I now request our next speaker, Dr. Vikas Singla sir. He is the Senior Director and Head of Gastroenterology in the Institute of Liver and GI Sciences in Max Super Speciality Hospital, Saket, New Delhi. He will be speaking on the topic endoscopic submucosal dissection. What are the indications? And he will throw light on the techniques.
Thank you, ma'am, for the kind words. Good afternoon to all of you. So I will be discussing a very exciting addition to our endoscopy, that is endoscopic submucosal dissection. So it's a technique to remove the mucosal lesions, that is early mucosal cancers or large colonic polyps, or lesions which are arising from the submucosa, that is like lipoma or sometimes maybe superficial anitis. They can be treated with the endoscopic submucosal dissection, and the plane of dissection is junction of upper 2/3 and the lower 1/3 of submucosa. That's why it's called endoscopic submucosal dissection. I think out of all procedures, it's a bit more challenging and the time consuming, and one should have a special interest and commitment before starting the EST. So we can see these are the various GI layers. First is the epithelium, lamina propria, muscularis mucosa, then is the submucosa, and deep is the muscle layer. So this is the plane of dissection for the endoscopic submucosal dissection. So anything which arises superficial to this layer can be treated with the endoscopic submucosal dissection. From mucosa we can have early esophageal cancer, early gastric cancer, or large colonic polyps. And similarly from the muscularis mucosa we can have a leiomyomas. And from submucosa, from superficial submucosa, sometimes we can have anites that can be removed with the submucosal dissection. So most of us have armamentarium for the EST. Doesn't require any special instrument, maybe some knives or extra cap is required. So first the scope should be high definition endoscope along with the auxiliary channel. So we need auxiliary channel because sometimes there is a bleed during procedure. So to clear the field we need a water jet. So water jet can be passed through auxiliary channel, and through the main channel we can pass our accessory and we can do the hemostasis. And to the tip of endoscope we have to attach a cap. Cap has many functions. It will separate the mucosa from the deeper layer. So it will give us a traction. And ESD should be performed only under CO2. Otherwise there is a risk of air embolism, and then we need flushing pump to clear the field with the water. And to stain the submucosa we need either indigo carmine or we need a methylene blue. And there are the various knives. The tip can be either a cutting tip knife or it can be an insulated tip knife. So this is the IT knife. You can see it's an insulated tip knife. So with this there is less risk of deeper injury. And other knives we can see with the tip we can cut. So it's a J-shaped hook knife, and most commonly used knife is the either dual knife or the flush knife. In India most commonly used knife is the dual knife. Then this instrument is a coy grasper. With the coy grasper we can, so sometimes there is a bleeding when we do EST. So with the coy grasper we can grasp the vessel, and then we can apply soft coagulation and we can also use hot biopsy forceps for hemostasis. Then to close the defect, especially in the duodenum or the right side of colon, we need either clips or we can use loop to close the defect that we will discuss later on. And there are various solutions available. So with the earlier knives we need two instruments, one for cutting and one for injection. Now the recently available knives, they have both cutting function and injector function also. So with the earlier knife we need a solution for a prolonged elevation. But now because with the dual knife we can inject and cut with the same knife. So most of us now we do ESD with the normal saline only. We don't need any special solution. And for the colon we mostly use jello fusion. And electrocycle unit is a mandatory part. It converts whatever electricity we get at our house is the low frequency current, 50 hertz current, and with this there is a high risk of neuromuscular irritability. So whenever we touch a wire, there is a local neuromuscular response. So this electro unit converts low frequency current to the high frequency current. So that current can be utilized for the cutting, and various modes are used. Like for marking, we use soft coagulation, and for incision we use endocut mode, and for submucosal dissection we can use either force cut, swift cut, or the precise cut. Any mode can be utilized depending on the expert's preference. Then for hemostasis we use the soft coagulation, and these are various steps. First step is the marking, especially for the flat lesion like early gastric cancer. There are flat lesions. So first we have to mark the boundary of the lesion. Then second step is injection. We have to elevate lesion from the deeper muscle layer. In ESD we have to avoid injury to the muscle layer. So we have to use injection. Then we have to initially give a mucosal incision on the normal mucosa. The incision should not be going across the tumor. Then we do the submucosal dissection. Then total separation of the lesion. So first we have to assess the depth of the lesion. For this we have three tools. One is the Paris classification. Like in colon cancer, if there is a colonic polyp, if it's a type 3. So type 3 means there is a deep cancer. So it's a colon type 3 are the deeper cancer. Similarly in the esophagus or the stomach also, if it's a type 3, it's likely to be deep cancer. It should be offered surgery or other treatment modalities. Most of the early gastric cancer are type 2C. Most of early esophageal cancer are type 2A. So colonic polyp can be anything between 1S to 2C. But type 3 are the colonic cancer. Any colonic polyp, deep ulcer, leave it for surgeon. So what is the principle of narrowband imaging or the BLI? So whenever tumor, so this blue area is a tumor. So we can see when we are going towards the right side, the depth of tumor is increasing. As the depth of tumor is increasing, there is change in the vessel caliber. So we can see that compared to left, on the right side, there is loop formation and diameter of vessel increases. So in NBI, we either focus on the surface pattern, that is gland pattern, or we focus on the vascular pattern. And with that, we can assess the depth of the cancer. So like in esophageal cancer, type A is the normal size vessel. So whenever we have a suspicion of esophageal cancer, we look for a surrounding area. We see size of surrounding area vessel. If it's a 7 micron, and then we compare it with the abnormal area. If size is same, it's an inflammatory area only, like it can be GRD. So if the type of vessel has become 3 times of the normal vessel, so we see size in normal area, then compare it with the abnormal area. So if size is 3 times, it's either B1 or B2. They are superficial cancers. If size is 10 times, that is 60 micron, it's a B3 deep cancer. Only B1 type of cancer should be treated with the ESD. So here this is the normal esophageal area, 7 micron. Here we can see size is same, but vessel are longer in size. So it's the same size, so it's likely to be inflammatory. This is 3 times. Now we can see the vessel diameter is 3 times of the first one. So this is 20 micron, but here it's a loop formation. So it's a B1, it's confined to epithelium and the lamina propria. ESD will be curative. There is hardly any risk of lymph node metastasis. So ESD will be curative. Now here we can see it's again 20 micron, but it is elongated vessel. It means tumor has gone to B3. B3 means the tumor has gone to muscularis mucosa or submucosa. So in this case, treatment is either chemoradiation or treatment is surgery. And in last one, the size is 60 micron. Here treatment will be surgery. It's a deep submucosal invasion. And these are Japanese guidelines. According to Japanese guidelines, this tumor is B1 pattern. It's confined to either mucosa or lamina propria. This tumor can be curative with the ESD. So B1 lesion 20 micron with the loop formation, ESD can be offered. So we can see here, some area of erythema in the mid-esophagus. On white light, early esophageal cancer, they appear as erythematous areas, and then we do the NBI. On NBI, we can see here area formation. So we can see on NBI, the color of this area is different from the surrounding area. So there should be area formation, and in that area, we can see vessel pattern is B1 pattern. So it's a early esophageal cancer. Then we have to mark the boundary of the cancer, because after the injection, sometime boundary may become obscured. So we mark the boundary of a tumor, then we give a injection and give a circumferential incision. So we have to give an incision all around the tumor. So here we are giving incision proximally and distally both. Then we do the submucosal dissection, and we have to keep the muscularis propria layer preserved. So here we can see that we are given incision, and after dissection, whole tumor can be removed. So up to 3/4 of circumference of esophagus can be removed. And biopsy showed it's a early esophageal cancer confined to squamous epithelium, and ESD is curative. If biopsy shows tumor has gone to deeper layer, it will require the chemoradium. Similarly, for early gastric cancer, we should have a demarcation line. So what is demarcation line? We can see this area of mucosa is totally different from the surrounding mucosa. So we can draw a line here where the surface pattern is totally different. There is no transition actually. There is no transition area. So this mucosa, so this is gland formation. This whitish area is a gastric gland. In esophagus, we don't have glands. We just see vessel pattern. Esophagus becomes squamous epithelium without any glands. In stomach, we see this glandular pattern is different from this area. So this is surrounding metaplasia. In center of metaplasia, we can see a cancerous area and with the abnormal vasculature. Right side also we can see there is a demarcation line with the irregular vessel. So this is a early gastric cancer. Here for assessment of death, NBI has no role. In early gastric cancer, white light is good enough to define the depth. Tumors which are confined to the mucosal layer are the smooth protrusion or shallow erosions and with the uniform redness. If there is a bulky fold and clump formation, it indicates it's a deep cancer. So only tumor which are smooth and the shallow depression, they should be ESD should be attempted in those cases. So again in stomach also, first we have to mark the boundary. So we can see a small lesion there on the, this is small lesion in the stomach. So again we have to mark that area. Then next step is injection. So if we are not getting good lift, it indicates either there is a deep infiltration or there is a submucosal fibrosis, and ESD will be challenging. Then we give a circumferential incision all around the tumor, and next step is submucosal dissection. So here we are dissecting below the tumor, and tumor can be removed. And this was a case of lipoma arising from the submucosal layer. This patient had intermittent episodes of gastric outlet obstruction, and here we can see a large lipoma around 8 cm in the antrum. Again we give a proximal incision, then we give a circumferential incision all around, doing a submucosal dissection, then separating lipoma from the deeper layers. And we can see that tumor has been isolated from the all around, and tumor can be removed. We can see a large lipoma separated from the deeper layers. And for the colonic polyp, we do the JNET classification. If on JNET, it's a type 1. Type 1 is hyperplastic. Type 2A is low-grade dysplasia. They can be removed with the piecemeal EMR also. Type 2B has a high chance of having a high-grade dysplasia or carcinoma in situ. This should be removed with the ESD. So here we can see a large polyp in the sigmoid colon. So this polyp is elevated. So in colonic polyp, we don't require marking. So polyp is, we can easily differentiate from the surrounding normal mucosa. So we don't require marking. So in colonic polyp, we make a tunnel. So first we give a proximal incision, and then we give a distal incision. So here we are giving a distal incision towards the oral side. Then we make a tunnel below the polyp. And now we are connecting both the tunnels. We are connecting both the incision, proximal and distal, and we have made a tunnel below the polyp. And here, last step is cutting the margins, and here we are closing the defect with the loop and clip technique. Dr. Sanjeev must be remembering a case we did together at Max. So he was actually very excited to see this technique of closing the rent. So we apply a loop to the margins, then apply clips, and then we tighten the loop. So we can see there is a mucosal defect only, muscularis is preserved, but sometime later on when stool comes in contact with area, there can be necrosis of vessel and there can be delayed bleed. So once we close the mucosal defect, especially in patient with the coagulopathy, delayed bleed can be prevented. Next step is we are tightening the loop and the whole mucosal defect can be closed. You can see here the whole defect is closed. And this is a polyp in the right colon, a sessile senated adenoma. So again, so ESD in the right colon sometimes can be challenging because of the long scope position. So technique is same, and to apply traction we can use a special technique. So here we are given an incision. So we make a loop, attach one end of loop to the polyp, and so we can see a loop there. So we have attached one end of loop to the mucosal flap, and other end of loop is attached to the colonic pole. So that will give us a traction, and then we can do submucosal dissection easily. This was a case of cirrhosis with the colonic lipoma. Patient was having recurrent episodes of bleed. We can see a large lipoma in the transverse colon. Again, steps are similar. We give an injection. So lipoma easy to treat. You can easily remove them. So again, first injection and then mucosal incision and submucosal dissection. Then after completion of dissection, we can remove the whole lipoma. So traction is essential part of ESD. Sometimes whenever we cut the mucosa, it falls back on the deeper layer and it's difficult to get the traction. So various technique can be used. So one is the cap with the, so here is the muscle side and other side is the mucosal side. So to separate the mucosa from the muscle, we can use traction with the cap. So here we are using traction and it stretch the submucosa, and the stretched submucosa can be cut easily. Other technique is the counter traction. As we mentioned earlier, this is a patient of ulcerative colitis with the early colonic cancer. So there are a lot of fibrosis there. So we can see we have made a loop, special loop, and we have attached one end of loop to the mucosal flap, and another end of loop is attached to the colonic fold. Now we can see that once we attach loop, now submucosa is stretched. So after stretching of submucosa, dissection can be done. Now its stretched mucosa can be cut easily. Otherwise it falls back on itself and difficult to find a plane. Here we can see a stretched submucosa, and ESD become quite easier, especially in patient with the fibrosis. And sometimes we can make a tunnel below the polyp, and it can give us traction, and the procedure becomes easier. And last, as I mentioned, regarding the defect closure, especially in patient with the duodenal polyp or the colonic polyp, where patient has where the wall is thin, or patient on anticoagulant or antiplatelet, we should close the mucosal defect to avoid the delayed bleed or delayed perforation. And sometimes during procedure there can be bleed. Here we can see, so we can see spurter there. So first we have to clean the area with the, you can see spurter there. So first we have to clean that area with the flushing, then localize the spurter, then grasp vessel with the coag grasper, and then apply soft coagulation to achieve hemostasis. To summarize, I think ESD is a procedure with the very high therapeutic potential, and it can avoid morbidity and possible mortality from the surgery in a patient who had early cancer or large polyp with the high grade dysplasia. And it's a technically challenging procedure. Whoever want to start ESD, I think you should devote time and dedication for the procedure. Thank you very much for your patience here.
Thank you, Dr. Singla, for excellent visual demonstration and lecture. Any question he can be allowed to answer because of time constraint. No questions. Thank you.
Thank you. Thank you.
Thank you, sir. Thank you so much for this enlightening session. Moving on to the next session, I would now request our next speaker, Dr. Kapil Sharma, sir. He is a senior gastroenterology at Sarvodaya Hospital, Faridabad. Many awards to his name, prominent of which are Travel Grant Award and Young Clinician Award. Sir has special interests in third space endoscopy and interventional EUS. Today he will be speaking on per-oral endoscopic myotomy for non-achalasia disorders.
First of all, I extend my sincere thanks to Team GastroCon Bihar for giving me this opportunity, and Dr. Jayant Ghosh as well. And Dr. Shri Hari has been talk about the non-achalasia motility disorder, and he made my job easy. Now, because these disorders are non-highlighted as achalasia cardia, but they are much more common. And the poem has been initially introduced for achalasia cardia. Now it started to gaining experience with these kind of non-motility disorder. Now I will be speaking regarding the per-oral endoscopic myotomy. POEM is a prototype of third space endoscopic surgery where the mucosal incision is made to make an entry into the third space, which is the virtual space created by the submucosal tunneling. Then you can perform surgery like a myotomy and endoscopic removal of submucosal tumor. Then you have to close the mucosal incision by multiple clips. Just to recapitulate that step of poem, here you can see in the first step mucosal incision was given, which should be greater than 2 centimeter. Then you need to dissect these fiber at apex to gain an entry into the submucosal space. Now you can say the entry becomes so easy after dissecting these fiber. And once you gain access into the tunnel, then you need to dissect. You need to stay close to the muscle, and your plane of dissection should be perpendicular to the muscle. Then you have to do a myotomy. Here you can see the myotomy being performed. And then you need to extend the myotomy 2 centimeter beyond G junction. It is very essential to close this mucosal incision to maintain the integrity of mucosa. And now coming to the per-oral endoscopic myotomy for non-achalasia disorder. POEM has been widely studied in the achalasia cardia, become a standard of care. Its role in the non-achalasia disorder is still evolving. The POEM is a prototype of tunnel endoscopy which can be utilized in other disorders. Here we can see the Z POEM for Jenkins diverticulum, D POEM for epiphrenic diverticulum, G POEM for gastroparesis, and the motility disorder rightly said by Dr. Sri Hari, hypercontractile esophagus and diffuse esophageal spasm can be treated by POEM. And here you can see some data for the POEM in the Jake-Hammer esophagus and the diffuse esophageal spasm. The efficacy is now similar to the achalasia cardia. Here you need a longer length of myotomy compared to the achalasia cardia. Now you can see the J POEM is the modification of the POEM where you utilize the tunneling to access the septum, then you dissect. Here you can see the last diverticulum can be seen by the CT scan. Various technique of Z POEM. The standard Z POEM, you do a mucosal injection incision proximal to the septum, submucosal tunnel, expose the muscular septum which contain the cricopharyngeal muscle. Then you do a myotomy till the base of diverticulum. Here is the problem in the closing that incision, because you made a mucosal incision in the cricopharynx, then you require a narrow space and sometimes closure can be difficult. Hence the modified POEM, here you directly inject on the septum, which make mucosal entry easy and closure is also easy. Mucosectomy sometimes give an additional advantage, because sometimes what actually happens, you dissect the muscle but mucosal fat remain, which may lead to the recurrence. In the hybrid Z POEM, you are not able to do a tunneling because of submucosal scarring. Just do a septotomy, identify the submucosal fiber, then make a tunnel and dissect the septum till the end of diverticulum. Here you can see in this Z POEM, you make a mucosal incision proximal to the septum, then gain access. Here you can see the septum, and which can be divided to the base of diverticulum. Subsequently, you can close the incision. Here you can see the septum being exposed in another diverticulum, and then you do a tunneling and myotomy. In open Z POEM, no closure of mucosal flap is required. Additionally, you perform a mucosotomy, and it should be reserved for the large Jenkins diverticula. Here you can see we are directly injecting on the septum. Then you expose the cricopharyngeal muscle as well as the septum, which contain the esophageal muscle, and then you start doing the esophageal myotomy, and subsequently these cricopharyngeal myotomy being you should take a care while dissecting the lower aspect of these cricopharyngeal muscle. And here you can see you made a submucosal tunnel, hence you can dissect these septum till the end of diverticulum once you start seeing the adventitia. In open Z poem, we are also dissecting the mucosal flap on both sides, on diverticular side as well as esophageal side, because sometimes these mucosal flap may remain in the large anchor diverticulum, which can lead to the high rate of recurrence. Here you can see on the esophageal side, at the end of dissection, you can see the complete mucosal flap boundary. There is no residual mucosal access at the bottom of diverticula. Immediately we do contrast study, don't find any leak, and the smooth passage of contrast into the esophagus and subsequently into the stomach. This is the first papers across the globe, and we have published a first open Z poem in the literature as a novel treatment for Jenkins diverticulum. It has been published in the prestigious Journal of Endoscopy, that is BJISGCON. Regarding the data about the Z poem is highly effective treatment for the Jenkins diverticula with very good clinical success rate of around 90%. Now coming for the D poem for large epiphrenic diverticulum. Here is our patient. In endoscopic image, you can see eccentrically placed G junction with large Jenkins diverticulum. As Dr. Srihari mentioned in slide, this is the jackhammer esophagus with the large epiphrenic diverticulum. These epiphrenic diverticulum always form with some kind of motility disorder in the esophagus. Here you can see the barium, which show the complete retention of contrast into the diverticulum and the esophagus. And then the D poem combined with the E poem was performed. This is the first we make an entry into the submucosal space, and then we start dissecting these submucosal fiber. Care was taken while here you can see this is the septum. This is the septum, this is the esophageal inlet, and this is the wide mouth of diverticulum, which is exposed by the submucosal tunneling. Then you start dissecting this septum. Here you can see the septum was dissected till the base, and then apex of the septum was dissected. And then you start doing myotomy on esophagus. This is, you can see here is the muscle is very thin, and we have extended our myotomy into the stomach side. Once the few remaining fiber of the septum were dissected, at the end you can see the complete division of the septum. And once you start seeing, now you can see your entry into the stomach become very easy, and this tight junction become a narrow, and then you have to close the mucosal incision. Day 2 we did a barium contrast study, which shows the smooth passage of contrast into the stomach. There is no retention of contrast into esophagus. Now coming for the gastric poem for the refractory gastroparesis. The indication of G poem, once your patient is not responding to optimal medical treatment for more than 6 months, no response to dietary modification, and his GCSI, the gastric cardinal symptoms index, is greater than 2. This poem procedure, G poem especially, you have to inject and create a bleb 2 to 3 centimeter proximal to the pyloric ring, and then you have to make a submucosal tunneling. Once you make a submucosal tunneling, then you delineate the pyloric ring, and this pyloric ring should be dissected, and you have to do some kind of myotomy 2 to centimeter proximal to the pyloric ring, and then you have to close a mucosal incision. In this video, you can see the G poem, which we have done in our case. Here you can see the spastic pylorus, and then you made a mucosal incision. And once you make a mucosal incision, then you gain access into the submucosal space, and then you are dissecting these fiber, and the intervening vessels were coagulated. Here you can see this is the pyloric ring seen from the inside, and it should be confirmed on the outside. And then you start dissecting this spastic pyloric ring, and some kind of myotomy of the enteral muscle is also required. Then you need to close this mucosal incision. Here you can see at the end, pylorus is widely open. Regarding the data of G poem in the refractory gastroparesis, it is not effective as the E poem for achalasia cardia. Here is the response is quite low. There is a meta-analysis regarding the G poem in the refractory gastroparesis, which here you can see 10 study 482 patient, response rate is around 61%, adverse effects is 8%. What are the predictor for the response? Pre-GPOEM GCI score is greater than 2.6 and retention of the marker greater than 20% at 4 hours. Now coming to the parallel endoscopic myotomy for non-achalasia disorder. The non-achalasia disorder is nicely talked about the Dr. Sri Hari. There are some technical modification required while you performing EPOEM in these disorder. Longer length of myotomy is required because the spasticity involve the variable length of esophageal body. And the length of myotomy you can select by reviewing the tracing of manometry and identifying the proximal border of high pressure zone. And sometimes the barium study and the endoscopic appearance of the upper spastic esophageal contraction also help you during determining the length of spastic segment. It's a debate whether you have to do LES myotomy for non-achalasia motility disorder without involvement of LES. What actually happens once you do you cut these spastic muscle, the propulsive force of esophagus may not be sufficient to push the food bolus across the preacher LES, and some suggest you have to do LES myotomy if it is not involving the LES. The risk of reflux is also increased, and you should restrict gastric myotomy less than 4 centimeter. To conclude, the role of POEM in non-achalasia disorder is still evolving. Longer myotomy is required in non-achalasia esophageal motility disorder. Although LES myotomy is a matter of debate, JADE-POEM is established treatment for Jenkins diverticulum. Although modified JADE-POEM and open JADE-POEM is still evolving, D-POEM provides a satisfactory result for the epiphrenic diverticulum. G-POEM response in gastroparesis is low compared to the other variant of POEM. Thanks for your patience listening. I will be happy to answer any query. I finished my talk in 11 minutes.
One or two questions. I think no questions are coming, so we can end the session.
Thank you so much, sir. I would now request the chairperson to felicitate our previous speakers, Dr. Sri Hari sir, Dr. Kapil Sharma sir, and Dr. Vikas Singla sir. Please come on the dais. I repeat, Dr. Sri Hari sir, Dr. Kapil Sharma sir, Dr. Vikas Singla sir. I would request everybody to please give a round of applause. I would now request our moderators to please felicitate the chairpersons. thank you to everybody present on the dais. Now, I would request Advocate Chandrajit Mukherjee, sir, to enlighten us on the topic of medical and legal aspects for doctors. We welcome you, sir.
Well, good afternoon, ladies and gentlemen. Well, this is a topic that I expect most people would not know that I'll be talking upon. So what all you all have seen was double Dutch to me. I could understand that English still has words which we don't understand. The same would perhaps be logical for you when I talk in the legal sense. So, as you would all know, that doctors are under the purview of medical negligence. I am here to talk on medical negligence and how you can save yourself to a certain extent. Of course, you cannot be sure what kind of case will be filed, not filed, but you can take some steps, basic steps that can save you from future legal trouble. Steps including the first one being communication. Of course, that has changed in the latest concepts of treatment. Communication has become more open for doctors where you consult attendants. It is not the patient that you see, but you will have to see the attendants as well. The attendant has to be given continuous consultations, which most doctors and most hospitals have now started following up in a routine manner, where there is a conference with the patient party, which was earlier not there. So that is one aspect that you have to be very careful upon, is to have a continuous relationship with the attendant party. What happens to the patient, what you are doing to the patient, how the patient is recovering. I mean, you all do it. You do it on paper, you counsel the attendants also, but there has to be one extra step so that there exists a continuous communication with them. The next that we see when matters come to court is the BHT, the bedhead ticket, the treatment notes, the nursing notes. Most of the time, they are not regular. The doctor says something, the nurse has to write something. That time lag and that communication between the treating team, the medical team, is found absent in the bedhead ticket, which becomes a very big thing when you come to court. It is very difficult for a lawyer to explain how things were written and why things were not written, which should have been written. Because you have to understand one thing, a case against a doctor is always pitted by a doctor. I take this liberty to say this here because in my experience I have seen that if I have to defend a doctor, I am always fighting against a doctor because there will be somebody in the profession who's pinpointing things. I don't know if you all have felt it or not, but then whenever a case of medical negligence is filed against a doctor, there has to be another team of doctors who will be against the person on whom the case is filed. So you have to be very careful with your documentation, with your records. And how a case can be filed. Most doctors would not know, but then let me tell you that for a case of, say, a liability of 1 crore on a doctor, all that the patient has to spend is 2,000 rupees. 2,000 rupees, I take a doctor for 1 crore. Now, whether the court finds the doctor guilty, not guilty, comes much later. But you are in court for a claim of 1 crore. Now, whatever is done, 1 lakh, 2 lakhs, 10 lakhs, 50 lakhs, the range is up to 1 crore. 7,500, the range comes to 10 crores. So you can imagine the vast disparity in the amount that is paid as court fees and the claim that will be claimed on the doctor. Whether insured, not insured, that comes secondary. But this is the range. This is, then that apart, what one should be careful about is your abbreviations, use of abbreviations. The gentleman speaking before me said so many things. He referred to something about a poem. See, for a layman like me, a poem would mean something else, but then for doctors it means something else. So you will have to be very careful on how you explain what you are doing to the patient, to the attendants. Because yours is a very technical, scientific subject. And you will be judged by a person who is not a doctor. That is where the trouble starts. Your case will be argued by a person who is not a doctor before a person who will judge you is also not a doctor. So you have to be extra careful. When you take consent, when you take notes for treatment, when you record the history of a patient, that care and attention should be there. Well, this is all for now. If you would like to ask some questions, I am here to answer.
Can we fight? Because you have to fight.
Sir, there is no choice. You have to fight. And what I said is for you to fight. So for you to fight, you need to do your groundwork properly. Because many a times I have seen in BHTs, the doctor says something, the junior doctor will write it. It is not written at that point of time, but maybe at 10 o'clock in the night when the junior doctor is free. And he will recollect something which the senior doctor while taking the rounds had said, and he will try to incorporate. Next morning when the senior doctor comes, he'll just do just a small sign and it's out. As long as nothing is wrong is fine. But when things go wrong, then it goes wrong in a big way. So what I mean to say is there should be a check and a recheck. Uske baad to it's like God's hands.
Any role of Medical Council of India? I think he is the foremost authority of India.
No, Medical Council of India is only for the doctors. Medical Council of India issues licenses to the doctors. It features the guidelines by which doctors will practice. But so far as courts are concerned, they have nothing to do with MCI. Courts are superior to the MCI.
You have to oppose. If you are in lending problem, you have to fight. You have to do dharna. You have to do slogans.
Sir, dharna and slogans with the MCI may work, but it does not work in court. Doctors are facing litigation every day throughout the country. I cannot say in any one particular place, but the law is such, and like I said, for 2,000 rupees the figure is 5 crores. You take a doctor up to 5 crores. So that's a huge amount. Anyone who's dissatisfied can file a case. And the new law says that the earlier law was where the case will be filed where the doctor resides or the doctor has treated. Now the law has changed. You treat a patient in Ranchi who comes from Tamil Nadu. He will go to Tamil Nadu and file a case, and the doctor treating in Ranchi will have to run to Tamil Nadu to fight that case. So this is the difficulty in law. Your patients are not local always. They come from other places. Patients from Ranchi go to Vellore, Delhi or wherever. Now imagine the plight of the doctor. Somebody treating a patient of Ranchi in Delhi does something, and you have a 2-year window to file a case. You come back to Ranchi, get treatment again in Ranchi, and you can file a case on that doctor in Delhi in Ranchi. Now when notice reaches that doctor in Delhi, he is helpless. Maybe he's never come to Ranchi for that matter, and he'll have to fight the case in Ranchi. Well, we cannot change that. This is the law.
How does the medical complication differ from medical negligence?
Medical complication, that's a very good question. Medical complication is something.
What about in surgery? When a surgical complication?
Let us not generalize it into surgery. I'll reply to your question. Medical complication is something which will arise, which is what you have been taught. Medical negligence is a thing in law which says that you are supposed to do something for which you are trained and you are skilled. If you don't do that with a reasonable skill and expertise that you are supposed to have, then that is negligence. Complications are welcome. You cannot change complications. It is your ability to deal with those complications at that point of time with the expertise and skill that you have will decide whether you have been negligent or not. Negligence does not mean that for every surgery it has to be successful. I don't say that. But negligence can only be proved when you are expected to do something as per your reasonable expertise and skill, which you have not done. That is where negligence comes into play. And it's a very thin area. You understand what I'm saying? How will you prove that? Who will judge you? So then comes the role of a medical board, a medical opinion sought by a team of doctors who will judge what you have done. As lawyers and judges, we don't know what you have done. So your actions will be scrutinized by a board, which will give an opinion this way or that way. That will further decide your case. So complications are welcome. There is no problem with complications. you are taught about complications and how to handle them. The problem will arise how you deal with it. Well, is that all then? Let me take this opportunity to thank GastroCom for allowing me to. Yes, sir, please. I can hear you, sir, no problem.
So the question was that the what the consumer protection laws, which is sort of started the troubles for the doctors, is no longer applicable to medical practice. So what is the actual situation?
Doctors, hospitals, any institute treating patients are all under the purview of the Consumer Protection Act. You will be liable for any act or omission done on your part before a court of law by the Consumer Protection Act. The first court starts in the district level, followed by an appellate authority in the state level, which again is on the national level, which we all know as the National Consumer Disputes Commission. And finally, orders of the National Consumer Disputes Commission can be challenged in the Supreme Court of India. So doctors and hospitals are liable. Guilt proved, not proved, it's a series of appeals. First court, second court, third court, and then the Supreme Court. But then doctors and hospitals are liable. That is the law. Well, thank you, ladies and gentlemen, for a patient hearing. I take this opportunity to thank GastroCon 2024 and Dr. Jayant Ghosh in particular for allowing me and inviting me to speak and share my experiences. Thank you so much.
Thank you so much, sir, for the insight. So here we have our next speaker. Before that, I would like to invite the chairperson for the next session, Dr. M.N. Singh, sir, Dr. Sanjay, sir, Dr. Sushil Pandey, sir, Dr. Majid Alam, sir, on the stage as chairpersons. So talking about Dr. Sanjay, sir, from Daltonganj. I would now request our next speaker, Dr. Mayank Sharma, sir, to please come on the dais and enlighten us on the topic of acute pancreatitis, a surgeon's opinion. Sir has completed his MBBS and MS from Assam and is currently a highly experienced gastrointestinal surgeon with a background spanning over 9 years, currently associated with Pulse Super Specialty Hospital, Ranchi. We welcome you, sir.
Code.
Very good afternoon to all of you. Thank you, GastroCon, for giving me a chance to speak in front of you. My topic of presentation is acute pancreatitis, a surgeon's perspective. So we all know that acute pancreatitis is a protein inflammatory process with a wide range of clinical presentation, which may be mild, self-resolving to most of the times, and sometimes to severe life-threatening illness. Most of the patients, 80% have mild disease and 20% only have complicating diseases. The mortality in mild disease is less than 3%, whereas where there is a gland necrosis, that is acute necrotizing pancreatitis, it is more than 17%. We have got revised Atlanta classification for mild, moderate and severe pancreatitis, whereas mild pancreatitis, no organ failure, no local complications. Moderate has transient organ failures, less than 48 hours, with some local complications, with or without some local complications, and severe has persistent organ failure, more than 48 hours with local complications. The local complications are acute peripancreatic fluid collections, acute necrotic collections, pancreatic pseudocyst and pleural effusions. So what is the role of a surgeon? The role of a surgeon comes when there is an abdominal catastrophe, like any ischemic bowel or bowel perforation, in cases of abdomen compartment syndrome and hemorrhage in the abdomen. Whereas if there is some etiological issues like cholecystectomy or ERCP, or management of the chronic pancreatitis, which is the cause of acute pancreatitis, and managing the complications of acute pancreatitis, which may be a severe sterile necrosis, an infected necrosis, a pseudocyst or walled-off necrosis, a pancreatic abscess or disconnected duct syndrome, or in very rare cases, extrahepatic portal vein obstruction, whereas sinistrial hypertension. So coming to abdominal catastrophes, there are bowel complications happening in acute pancreatitis, seen in 10 to 27% of severe acute pancreatitis or necrotizing pancreatitis. Most common are ischemia, perforation and fistula. Mostly occurs due to venous thromboembolism due to inflammatory process. Diagnosis is a bit difficult process because no of the imaging modalities are very much sure-shot about that. It depends upon the clinical acumen of the clinician as well as the diagnostic modality. CT is the imaging of choice. Median time of presentation is 25 days. Treatment of choice is resection with proximal diversion. Abdominal compartment syndrome, we all know that it is defined as intra-abdominal pressure more than 20 mm of Hg with new organ failure. Usually happens due to massive fluid resuscitation with leaky capillaries and resulting in third space loss. Clinical diagnosis as well as intravesical pressure management is important. CT scan is the modality of choice to imagine them, which shows compressed IVC, sometimes renal compression with displacement, bilateral herniation, elevated hemidiaphragm and round belly sign, which is seen as AP diameter is to transverse ratio more than 0.8. The treatment from surgical side is decompressive laparotomy with resection of any non-viable bowel. Coming to hemorrhage, affects only 1 to 3% of cases. It is associated with high mortality. The clinical features are increased pain abdomen, GI bleed from upper GI bleed or lower GI bleed, or sanguine noticed in the abdominal drains. Imaging of choice is CT angiography. The treatment can be done by interventional radiologist as coil embolization and stent placement. If not available, damage control surgery should be done, laparotomy with packing of the bleed, and second look laparotomy should be done to remove all the necrotic tissue and to control or exclude the aneurysm. Removal of necrotic tissue is essential because if not done, then it will lead to more aneurysm and more bleeding, and repeat chances of bleeding are more. For etiology, there is a debate when to do cholecystectomy in acute biliary pancreatitis, because GSD is one of the most common cause of acute biliary pancreatitis. Imaging USG and MRCP are good enough to diagnose them. Time of cholecystectomy is debated. Patients with mild disease, cholecystectomy can be done during index admission, preferably, or the surgery can be deferred till acute inflammatory process resolves. CBD exploration should be done if preoperative ERCP is not done in cases of CBD lithiasis. For ERCP and biliary drainage, the most common debate is when to do the ERCP. Urgent decompression of the biliary tract is indicated, that is within 24 hours if there is an acute biliary pancreatitis with signs of cholangitis. And elective decompression of biliary tract can be done within 72 hours if there is acute biliary pancreatitis. There is biliary obstruction, but there is no clinical signs of cholangitis. It should not be attempted in acute biliary pancreatitis where there is neither cholangitis nor CBD obstruction. So for etiology, if the cause of acute pancreatitis is itself a chronic pancreatitis, which is mostly diagnosed on imaging as tortuous MPD with strictures plus minus stones. We have got both the treatments, endoscopic management and surgical management. For surgical management, we can have a drainage surgery like pusto surgery or phrase surgery. And for endoscopic management, we have got ERP plus sphincterotomy. The sphincter can be dilated with hydrostatic balloon dilatation, sphinctoplasty. We can have MPD stenting or transpapillary and mural endoscopic procedure. That means we go inside the MPD, take out the stones. We can break them by lasers and take out the stones. Coming to complications, the most common seen is acute peripancreatic complication. It usually occurs early in the course of disease within 4 weeks. There is no encapsulating walls, and the collection is confined to the normal fascial planes. The content are sterile. Acute peripancreatic collection usually occurs in mild pancreatitis, whereas acute necrotic collection occurs in necrotizing pancreatitis with a CT score of more than 6. So if the collection is sterile, there is no point of doing any intervention to them. It is only indicated when there is symptomatic pressure effects. We can have image-guided percutaneous drainage from retroperitoneal site, transperitoneal site, and even transgastric sites. US-guided drainage from transpapillary and transmural are also technically demanding and upcoming processes. While coming to infected necrosis, it is the absolute indication for intervention. Suspected in patients having fever, leukocytosis, patient with severe acute pancreatitis with organ failure or who don't improve in first 2 weeks. The definitive way of diagnosing infective necrosis is FNA, but it is not routinely done. However, a gas in the necrotic tissue on CT scan is very much indicative of the necrotic infected necrosis. It is having a high mortality rate of even 100% if left untreated. Intervention approach or step-up approach, which was proved by Penter's trial. Methods are minimal access method and open surgery. When you come to minimal access method, we have got percutaneous drainage by retroperitoneal routes, transperitoneal routes, and even transgastric routes. We have got EUS guided drainage by having SEMS placement, but we know that maybe multiple settings of EUS guided necrosectomy may be required. Retroperitoneal approach, also called as VARD, which is video assisted retroperitoneal debridement, also called as sinus tract surgery, can be used, where we first put PCD, which drains the collection, and then it is used as guide. The tract is dilated, ports are placed, and a videoscope is inserted, and all loose tissue are removed with drain placed for lavage. And next, minimal access approach is laparoscopic approach. We can go for laparoscopic necrosectomy by transgastric route, gastrocholic route, and even transmesocolic route. And the necrosed tissue should be identified and it should be removed. Gentle handling is must for necrosectomy. Drains are placed after completion of the process for continuous lavage or simply drainage of the areas. Now, if we try for open surgery, the principle of the surgery remains the same for the laparoscopic approach as well as the open approach. But in open approach, we go for midline laparotomy and we remove all the tissue by transmesocolic approach or a retrogastric approach. And post necrosectomy, a closed continuous lavage is given and a closed drainage system are put. Now, treating with pseudocyst or walled up necrosis, usually they have a late presentation of more than 4 weeks, which is required for the cyst to have a granulation tissue covering all throughout. The pseudocyst is rich in amylase rich fluid, and walled up necrosis has got necrotic debris plus enzymatic fluid. Intervention is required when they are symptomatic. We can go for EUS guided intervention with plastic stents, mostly for pseudocyst where the content is only liquid, and SEMS for necrotic collection. And in surgery, we can go for cystogastrostomy, whether open or laparoscopic, or we can go for Roux-en-Y internal drainage. Now, pancreatic abscess, they are different from the pseudocyst or walled-off necrosis. They are defined as pus-filled cavity near the pancreas due to acute pancreatitis or pancreatic pseudocyst infection. But the cavity is thick-walled, whereas the pseudocyst is a thin-walled. So imaging, CT scan is the imaging of choice, where we can see a thick irregular wall cavity. In a hemodynamic stable patient, we can go for surgery, debridement and internal drainage. If the patient is not hemodynamic stable, we can have minimal invasive methods like image guided PCTs and EUS guided drainage. Now coming to disconnected pancreatic duct syndrome, it is a rare complication, which means that there is a circumferential disruption of the continuity of pancreatic duct between viable secreting distal pancreas and proximal necrotic pancreas. The imaging of choices are CT, MRCP, ERCP and fistulography. It can present as ascites, external fistula, recurrent collection, uneven pseudoorganism. The diagnostic criteria is necrosis more than 2 cm of the pancreas, viable pancreatic tissue upstream, that is the distal pancreas, extravasation of the contrast material injected into the MPD at ERP, and duct in the pancreatic tail segment should make an angle of 90 degree with the collection. So when it comes to management, apart from management of the nutrition and this infection, the collection can be drained as image guided or surgical. ERCP can be done with installation of stent between both the detached ends. Surgery is usually done after 6 weeks when the output is more than 100 ml per day for 3 months. The surgical options we have are Roux-en-Y internal drainage in form of pancreaticogastrostomy, pancreaticojejinostomy and fistulojejinostomy. However, we can go for distal pancreatic resection also. So, lot of slides have been seen, lot of methods have been seen, whether it can be a PCD or a US guided method or a laparoscopy or open surgery, but when to choose which one? It is said that surgery is a gold standard, transcutaneous approach have high chances of pancreatic fistula. Endoscopic is quite technical demanding process, but if we see a necrosum which is in the mid of the pancreas, it can be done with endoscopic method or a lab transgastric method. If the necrosum is or ward of necrosis is extending to the one of the lumbar areas, wards is a good choice, and if bilateral lumbar areas are included, then open surgery can be a good choice. So here is a video. Here is a video showing endoscopic pancreatic necrosectomy. This patient had a surgical cystogastrostomy in the index surgery. He did well fine with the surgery. He went to the job, and secondly, he had a He had a I don't know why it's not coming. He had again a pancreatitis attack, and he went into necrotizing pancreatitis, which was infected. So, So when he came to me, I took the history and I knew that there is a surgically made a hole between the gastric part and the walled off part, necrotic part. So we went through the endoscopy and we placed a stent inside that hole which was extending into the walled off necrosis. Then we dilated that hole with a balloon dilatation, and we can see a lot of pus is coming out. After we did that, we went inside that cavity and we took out whole of the necrosum in chunk. And I was lucky that it needed only one session, and he was fine with the procedure and he was discharged. So my take-home message is that if a surgeon is asked for his perspective, the perspective depends upon the function of the time. There was a days of open surgery, and laparoscopy when introduced was not well accepted, but later on we gained expertise in laparoscopy, and now a surgeon is entering into the endoscopic process, so it depends upon your expertise and your interest level. Thank you.
Nice presentation, Dr. Mayank. The house is open for discussion. If no questions, I will ask a question then. So there is still an indication for surgeons like traumatic pancreatitis.
Yes, sir.
Okay. So in traumatic pancreatitis, a surgeon will be called. Okay, there can be ductal injury, so that point should have been covered. And one point is that there are still some situations where there can be a dilemma in acute abdomen, whether this is acute pancreatitis or there is peritonitis because of any other disease. So in that situation also surgery is called for, and sometimes surgical intervention may be needed.
So in a traumatic pancreatitis where duct is injured, it will ultimately lead to disconnected duct syndrome. Right. So disconnected duct syndrome We have got all. If the surgeon is well versed with the ERCP, he can put a stent between both the ends. He can come out. If he is not expertise in this one ERCP, he can go with the surgery also, depending upon the case-to-case basis. That's the thing.
Dr. Mayan, what should be the dilatation of MPD for LPG?
Dilatation. It should be more than 6 mm, sir.
Oh. If less than 6 mm, can we do it?
If it is less than 6 mm, there are strictures. So there are two things. We have to see whether the stricture is in the head or it is a distributed stricture. For a head stricture, we can go for ERCP and dilatation with a stent. For a distributed stricture, we can go for this one, LPG.
Yes, I have done with a small MPD dilatation, and that did well.
Yes, sir.
There are certain situations where even a non-dilated can be.
Yeah. Because it is not about only the stricture and the stones, it is about the lithogenicity of the pancreatic juice.
And the symptoms of.
Yeah.
Thank you for your nice presentation for a common subject. Thank you.
Thank you, sir.
Thank you so much, sir. I would now request Dr. Ranjan Patel, sir, to throw some light on the topic of interventional radiology in portal hypertension. We welcome you, sir.
A very good afternoon to one and all. I would like to thank BJISGCON to inviting me for a talk. Today I'll talk about the interventional radiology in portal hypertension. It's a little bit different from the conventional gastro topic. So radiological intervention in portal hypertension includes diagnostic as well as therapeutic services. Among the diagnostic services, the most common are the liver biopsy and HBPG measurement, and therapeutic procedures are done to treat the complications of portal hypertension. So coming to the liver biopsy first, this is a case scenario, a case of cirrhosis, cause is not known. There is no ascites, INR normal, platelet count was also around 80,000, so everything was fine. So this is an ideal candidate to go for percutaneous liver biopsy. So we did a percutaneous liver biopsy, and nowadays whenever we do percutaneous liver biopsy, particularly in patients with cirrhosis, after doing the biopsy, we embolize the tract with the gel form slurry to prevent the complications of bleeding from the hepatic capsules. So what are the advantages of percutaneous liver biopsy? The core quality is good as compared to a transjugular liver biopsy. Obviously, it is cheaper than transjugular liver biopsy, almost 10 times cheaper than transjugular liver biopsy. The most important advantage of percutaneous liver biopsy is to biopsy a focal liver lesion, where in TGLV you cannot biopsy a focal liver lesion. To biopsy a focal liver lesion, you have to have a percutaneous liver biopsy. However, it carries a risk of capsular bleeding. Another case, the patient with ALF having moderate ascites and an elevated INR of 2.3. So this patient has a increased risk of bleeding if we do a percutaneous liver biopsy. So this would be an ideal candidate to go for transjugular liver biopsy. So how a transjugular liver biopsy is done? Initially a jugular access is taken. First right hepatic vein is cannulated, then the vascular sheath is placed, then the biopsy gun is placed, and then biopsy is taken under the fluoroscopic and ultrasound guidance, and in the end we just take a venogram just to confirm there is no transcapsular bleed. So what is the most common indication of transjugular liver biopsy? If patient is having ascites or coagulopathy, these two are the most common indications. Although we can do transjugular liver biopsy simultaneously if we are planning for other transvenous procedure like TIPS. The disadvantage are this procedure is costly because hardware is around 50,000 and we cannot biopsy a focal liver lesion. So if we won't be able to do a biopsy from the transjugular approach, in some cases we would be able to do through the different approach like a transfemoral approach. This is a case, there is a sharp angulation between the IVC and the right hepatic vein, so we could not do through a transjugular approach, and finally we did the biopsy from a transfemoral approach. That means we access through femoral vein approach, we hook the hepatic vein and we did the biopsy from the transfemoral approach. So generally we have a tendency to correct INR in patients with cirrhosis when we are planning for a biopsy, particularly in patients with elevated INR. But to remember, in patients with cirrhosis, INR is not a true reflector of coagulopathy. These patients have a concept of revalent hemostasis, and injudicious use of blood products could be detrimental in an attempt to correct INR. So if you have a facility of thromboelastogram, you can have a thromboelastography, see whether thromboelastography is normal or not. Irrespective of the INR values, if thromboelastogram is normal, then you can go ahead with a percutaneous liver biopsy. The next intervention is the hepatic venous pressure gradient. The venous pressure gradient is measured by subtracting waist hepatic venous pressure from pre-hepatic venous pressure. If it is more than 5, it is called as portal hypertension. If HVPG is more than 10, then it is called as clinically significant portal hypertension, and these have a high tendency of hepatic decompensation. And if HVPG is more than 20, then these patients have a high risk of pre-bleeding after initial variceal hemorrhage. So coming to the variceal bleeding, so first I'll be discussing the gastric variceal bleeding. Gastric varices bleed less commonly than esophageal varices. However, when they bleed torrentially and they are difficult to manage on endoscopy also. Like esophageal varices, if patient is bleeding from the gastric varices, the initial modality is the endoscopy. It is diagnosed on endoscopy, and initial hemostatic control is also attempted on endoscopy. If the endoscopic hemostatic measures fails, or if patient rebleeds even after the hemostatic control on endoscopy, then a role of endovascular therapy comes. The endovascular therapy can be TIPS, antegrade or retrograde variceal obliteration, and the type of therapy the type of endovascular therapy is chosen on the basis of anatomy, clinical profile and expertise of the operator. So the basic concept of gastric varices, first we'll just discuss the basic anatomy. The varices has a 3 component. One is the varices per se, one is the afferent system which is fed by left gastric, short gastric or posterior gastric vein, and in 80 to 90% of cases the gastric varices drains through gastrorenal or gastrocaval shunt. And unlike esophageal varices, this gastric varices has a tendency to bleed even at a lower pressure. So when a patient is bleeding from the gastric varices, the primary aim should be obliteration of the varices, not only the reduction of the portal pressure. So whenever, even if we do a TIPS to reduce the portal pressure, we have to combine variceal embolization along with the TIPS to control gastric variceal bleed. So there are different approaches. If we embolize through the efferent vein, then that is called retrograde embolization. If we embolize through the afferent vein, that it is called antegrade embolization. And if we embolize through the TIPS route, then that will be called it as trans-strip embolization. This is also a type of antegrade embolization only. So what are the options we have in gastric variceal bleed in terms of endovascular therapy? We have 3 options, that is transjugular intrahepatic portosystemic shunt, retrograde variceal obliteration or antegrade variceal obliteration. If patient is suitable for both TIPS and retrograde variceal obliteration, then we have to choose depending upon the clinical profile of the patient. If patient has history of previous hepatic encephalopathy, or if patient is having poor hepatic reserve, then if we do TIPS, that would further worsen the liver function and hepatic encephalopathy. So in such patient, the ideal intervention should be retrograde venous obliteration, that is BRTO, PARTO or CARTO. Whereas if patient has a good liver function and associated
হ্যালো, ও খুঁজছে ওখানটায়। ঠিক আছে, ঠিক আছে, হ্যাঁ লাইভ চালু হবে, দেখছি। ঠিক আছে।
Good afternoon. I'm Dr. Sanjeev in the middle of ERCP from Orchid Hospital. Dr. And as you can see, the stone is infected and repair. I have located the stone in the upper bile duct. The stone is heavily impacted. So I'm going to start lithotripsy with EHL. I will start with high energy and high pulse because the stone is impacted. Plus. It's not working. Plus. Okay, now you can continue with your talk. It will take, I think, 15 to 20 minutes for me to break the stone completely. So you can continue with your talk. We'll come back after some time.
Let's move to a case scenario. This is a patient with alcohol-related cirrhosis having IgB1 bleeding varices. Patient also had recurrent bleed in the past, which was controlled with endoscopic glue. Patient is having preserved liver function like B7 and also having grade 1 HE. So in these cases, we also did a CT portogram which showed a 1 centimeter gastrorenal shunt with gastric varices. In this case, the treatment option, endovascular treatment option would be of two, either tips with variceal embolization or a retrograde variceal embolization, that is BRTO or PARTO. But as patient had grade 1 HE, we proceeded with PARTO. So what is PARTO? It's basically a method of retrograde variceal obliteration which is done using a vascular plug. So we access the shunt through a transfemoral approach. Then we took a run, confirm that whether we are in shunt or not. After accessing the shunt, we close the efferent, that is the gastrorenal shunt, using a vascular plug. Then after closing the vascular plug, we started injecting the sclerogent mixture to embolize the varices. And in the end, we deploy the vascular plug and remove out everything, leaving only the plug and the sclerogent that will embolize the entire varices. So this is kind of a one-stop solution to embolize the entire gastric varices. And this is the 6-month follow-up. You can see there is complete resolution of the varices. The first is the initial immediate post-procedure CT, and this second is the 6-month follow-up images. So shunt occlusion can also be done in patients with medically refractory HE which are shunt related. So this is a case, you can see there is a bunch of shunt. This is basically a rhinorenal shunt running into the left renal vein. So in this case, we approach through a jugular approach, cannulate the left renal vein. Then from the left renal vein, we enter into the shunt. We block the shunt with a vascular plug, and we embolize the shunt using a sclerosing mixture. And this is the post shunt occlusion CT, which you can see there is a stagnant sclerosant column and the vascular plug. So importantly, what are the indication and contraindication of RTO? RTO means I am talking about the BRTO, PARTO and CARTO. So rather than the indication, the contraindications are important. If patient is having very advanced liver disease like CTP 14 or 15, then obviously any kind of intervention wouldn't have a great outcome. And if patient is having gross ascites, portal vein thrombosis or large esophageal varices, such patients also should not subject to retrograde variceal obliterations. So what are the other types of RTO? If we use balloon instead of vascular plug, then we call it as BRTO. If we cannot cannulate the shunt using a balloon or vascular plug, we can block the shunt using multiple coils. If we use coils, then it is called as CARTO. So the variants of RTO, BRTO, CRTO, and CARTO. So what are the IR options in patients with esophageal varicose bleed? Usually most of the patients are diagnosed and managed on endoscopy. However, in a subgroup of patients who have uncontrolled bleed even after the therapeutic endoscopy, then salvage tips is a viable option. And even in patient have controlled bleeding on upper GI endoscopy, in a subgroup of patients have a high risk of rebleeding. In such patients, we can do early tips within the 72 hours of endoscopy, which is called as preemptive tips. So this is a case of refractory esophageal varicose bleed. We took the patient in the midnight. We inserted a 8 mm tips shunt, and along with it, as patient was actively bleeding, we also took a run from the esophageal varices, and then we embolized used glue. And this is the final run. You can see in the fourth images there is a disappearance of the varices after tips and varicose embolization. So what are the other indications of tips? The most common indication in the refractory ascites are rapidly refilling ascites, and the other indications are hepatorenal syndrome, portal vein thrombosis, Budd-Chiari syndrome, and refractory hydrothorax. So what does TIPS do? Basically, TIPS is a shunt between the portal vein and IVC or heart. So it directs the flow from the portal vein into the heart, and it steals the blood flow away from the liver. So if patient is having a poor liver reserve, then it will make the liver further deprived of blood flow and may worsen the liver function. And simultaneously, it also increases the cardiac preload, so it may exacerbate cardiac dysfunction after TIPS in patients with marginal cardiac function. So in patients with poor liver reserve, or a patient is having recurrent HE, or patient is having congestive heart failure or severe pulmonary hypertension, in such patients TIPS is contraindicated, and other modality like BRTO should be opted. As I told, TIPS increases the cardiac preload, and majority in a subgroup of patients with liver cirrhosis, these patients have cirrhotic cardiomyopathy also. So if we want to do a cardiac evaluation prior to TIPS and directly do a TIPS, that would lead to cardiac decompensation in patients with subclinical cirrhotic cardiomyopathy. So this is a case of refractory hepatic hydrothorax on the right side. Initially, we entered through the jugular vein into the right hepatic vein. From the right hepatic vein, we punctured the portal vein. After puncturing the portal vein, we dilate the entire tract using multiple balloons. We measure the tract length, and ultimately we place a tip stent of 8 mm. And this is the 1.5-year follow-up. You can see there is complete resolution of the right-sided hydrothorax, and there is also patent tip stent. This is another case of refractory ascites, and we did a TIPS with 10 mm stent, and this is the 1-year follow-up. There is no perihepatic fluid, complete resolution of the ascites, and there is patent TIPS shunt. The next, moving to the ectopic variceal bleeding. Ectopic varices and gastric varices, these are the two varices which can bleed even at a lower portal pressure, like less than 12 mm Hg. So in such cases, if patient is bleeding from a ectopic varices or gastric varices, important point is to embolize the varices per se, not only to reduce the portal pressure by using TIPS. So this is a case of cirrhosis and bleeding from the colostomy site because of the ectopic varices. Patient had CTP 9 and moderate ascites. There was no HE. As patient had ascites, we planned a combined procedure with TIPS with variceal embolization. So initially we entered through the transjugular transhepatic route to the portal vein, from the portal vein into the IMB. This is the IMB run. You can see multiple varices at the colostomy site. Then we embolized the varices using coil and glue, and at the end we inserted a TIPS shunt. So this is basically TIPS with antegrade variceal embolization of the IMB varices. And this is a 3-month follow-up. You can see there is complete resolution of the ascites also, and there is also no varices at the colostomy site. Moving to the non-cirrhotic portal hypertension, these have a different clinical profile than the cirrhotic portal hypertension. The most common presentation with a variceal bleed, ascites, hepatic encephalopathy, and liver failure are uncommon because these patients usually have a preserved liver functions. So this is an example of ectopic varices in a patient with extrahepatic portal vein obstruction who had refractory bleed from the D2 varices. You can on the CT scan there are multiple varices on the D1 and D2, and there are segmental occlusion of the portal vein. So we inserted through a transhepatic route cannulate the portal vein, cross the stricture part of the portal vein, and you can see in the first image there are multiple varices in the segment of the portal vein which is bleeding into the D2. So we cross the stricture using multiple guide wires, then we dilate the stricture and we inserted stent, and this is the 3-week post-op follow-up. You can see there is patent stent and there is resolution of the varices. This is another case of EHPBO, non-cirrhotic, having multiple bleed, and you can see the first CT image, there is no patent portal vein, it was replaced with multiple cavernoma. There is a large left dilated tortuous left gastric vein. And in the coronal images, you can see there is multiple bunch of varices which is bleeding into the gastric lumen. Previously, US coil plus glue was also done. Still, patient had recurrent bleeding. And in the coronal images, you can see this is the SMB, and there is a thin stream of portal vein, and there was no patent visible intrahepatic portal vein branch. Because intrahepatic portal vein branch were not visible, the direct percutaneous transhepatic approach or TIPS creation was not possible. So after a multidisciplinary team approach, we planned for a hybrid procedure. We took the patient to the OT. Our gastrosurgeon opened the mesentery. They gave us access from a small ileocolic vein. From the ileocolic vein, we entered into the SMB. We took a run from the SMB. This you can see. This is a small portal vein stump, and this is the enlarged left gastric vein which is feeding into the gastric varices. So then using a guide wire, we inserted through the small portal vein stump into the hepatic parenchyma, placed a snare there, and from the transjugular approach we target the snare because we didn't have a targetable portal vein up front. So we placed a snare inside the liver, we target the snare from the jugular approach. Then once we catch up the wire from the SMB approach, then we had a through and through access from the IBC to the SMB. Then we dilated the tract and we created a mesocaval shunt. So this is basically a hybrid mesocaval shunt with both surgical and endovascular approach for refractory variceal bleed from the gastric varices. So after discussing the cirrhotic portal hypertension and non-cirrhotic portal hypertension, another entity is the left-sided portal hypertension. This is also called sinistral portal hypertension, and the most common etiology is the splenic vein thrombosis. The most common cause is either acute or chronic pancreatitis, and these patients usually have a different hemodynamic from the cirrhotic portal hypertension. So what happens in patients with splenic vein occlusion, the entire splenic venous outflow diverted through the stomach lumen, that means it diverted through the posterior or short gastric vein and then drain into the portal venous system through the LGV and form isolated gastric varices. So unlike cirrhotic portal hypertension, the flow in the LGV or in the PGV will be different, means it will be hepatofetal in the left-sided portal hypertension, whereas in the cirrhotic portal hypertension, the flow in the left gastric vein will be hepatofugal. So as the portal pressure is normal in case of left-sided portal hypertension, TIPS is not going to help. Thus, TIPS is not recommended as a treatment modality in patients with bleeding varices from the left-sided portal hypertension. So what are the options we have? Either we can directly embolize the varices either through an antegrade or retrograde use, or we can reduce the volume of the splenic parenchyma by doing a partial splenic embolization so that the splenic outflow will be reduced and hence there will be decrease in the pressure in the varices, because the varices is entirely the byproducts of the splenic outflow. And the other options is if you treat the cause, that means recanalization of the splenic vein. This is one of the example. You can see patients with mid part of the splenic vein is not seen, and there are multiple varices in the gastric wall. So we access a small intrasplenic branch of splenic vein. Through the transsplenic route, we cannulate the feeder of the varices. We took a run, you can see the bunch of vessels, then we embolized with glue. So this is basically a transsplenic variceal embolization in a patient with left-sided portal hypertension. Another patients having pancreatitis related varices, you can see there are a bunch of varices in the gastric fundus, and that is draining through the LGV into the portal system. So in this case, we did a partial splenic embolization to reduce the splenic outflow and to reduce the pressure within the varices. Sometimes some kind of IR guided interventions ask for the other kind of IR guided intervention due to complications. This is an example. You can see patients with cirrhosis, plantar tips. We thought the ascites will be drained before the tips because procedure will be easier. But after placing a 8 French pigtail, you can see patient developed a massive abdominal wall hematoma. Immediately we took the patients to the CT room. We did a multiphagic CT. You can see there is active bleed into the hematoma. Immediately patient was transferred to the DSA room, and left gastric artery, left inferior epigastric artery run was taken, which saw active extraction from a small branch that was embolized with glue. And after 3 weeks, the patient finally underwent tips. So to conclude, IR is basically a complementary, it's not competitive to the endoscopic interventions. Either it can be used as a salvage therapy when endoscopy won't help. We should have a clear understanding of the pathophysiology and anatomy, and we must need a pre-procedural imaging to plan interventions. It's not always the ideal intervention should be offered to the patients, rather it is influenced by anatomy, clinical profile and expertise. If patient is actively bleeding, the strict selection guidelines may not be applicable, and a case-based approach should be followed rather than a guideline-based approach. Thank you.
Thank you, doctor, for your nice presentation.
I'm working in Bhubaneswar.
यहाँ पे
M.
Yeah, good afternoon everybody. So we are live from the endoscopy suite here, and I have a big team with me here to support me and guide me in this case. So basically, this is a middle-aged male and who was incidentally diagnosed to have a subepithelial lesion on the endoscopy. And the aim of this session is to visualize this subepithelial lesion on the endoscopic ultrasound, and also to take fine needle cytology or biopsies. So can we just have the endoscopic image larger? Can you just shift this? So I'll just try to show you this lesion here on the EUS. This is not a forward wing scope, so bear with me on that. Can you all see this lesion here at the bottom? Is this lesion visible? Yes. Are we audible there in the hall?
Yes. Yes, sir.
Yeah. So can you see this lesion at around 5 o'clock? There's a subepithelial lesion here at 5 o'clock on the lower right of the screen.
Yes.
Yeah? So this looks like a subepithelial lesion. Now we no longer say submucosal. It is called as a subepithelial lesion because any lesion which is beneath the epithelial layer is a subepithelial lesion. Obviously, when we take biopsies from this lesion, it might not be conclusive because biopsies are always mucosal. And in such cases, it is always warranted that you evaluate these such kind of lesions by doing an endoscopic ultrasound. So the technique of endoscopic ultrasound, the scope insertion remains the same. The scope is slightly bulkier than your normal endoscope. So that sometimes is a challenge with short necks and all. So now I'm trying to focus this lesion. Can you take the this lesion? Yeah, the US lesion larger.
By the look of it, what kind of lesion is expected?
So sir, on the white light endoscopy, any subepithelial lesion would look similar. But on white light endoscopy, there are certain things that you would like to see. Basically, you will see for there is any superficial ulceration over the lesion, which is very common in cases of neuroendocrine tumor. Okay. Because the NETs are usually very superficial and they tend to grow more superficially rather than deeper. Other things that you see, the surface usually smooth in subepithelial lesions. You see for any vascularity overlying that on the endoscopy. And the most important thing that is usually seen is what is the location. So lesions which are in this location in the esophagus,
subepithelial lesions are more likely to be leiomyomas rather than a GIST. If a similar lesion would have been seen in the stomach, it would be more likely to be a GIST. So at G junction, you are very likely to get leiomyomas more often than a GIST. So now, if you see on the US, can you all see the US screen?
Yes, very much.
Yeah, so we are about to see this image. If you can see on the, I'll just mark this out. If you see over here, I think this is the lesion here. Still not very clear if this is the lesion or not. So in such cases, we put in some water. We put in water and see if we can delineate this.
Can you also enumerate the various layers?
May I request Dr. B.K. Agarwal and Dr. Dayal to please come over the dais?
Yeah, so for the layers, we'll have to first focus this lesion and then magnify and then see if we can see the layers. Obviously, this is a very small lesion. It looks like, I think you can all appreciate that the lesion is slightly coming into the picture. I'll put in more water now. I'll put in more water. The idea here is to gradually put in water. And I think you can all appreciate this ovoid kind of a subepithelial lesion here, which looks hypoechoic. Yes. Can you see this? Yes. Can you see this hypoechoic lesion here?
Yes, yes.
So the thing that we do in such cases is measure this, because this might be required when you plan therapy. So I would just measure this lesion. It looks in the longest diameter, it is around 11.8 millimeters, and in the short diameter, it is around 6.2 millimeters. Right. So again, I unfreeze, and then we see for if there is any underlying vascularity. You put in a flow, and you don't see any vascularity within this lesion. You don't see any vascularity within this lesion. So it's a avascular kind of a lesion. Looks fairly homogeneous. So we'll remove the flow, and now we'll try to see the layer of origin. Can you put in more water, please? Now the location is such that the water will not stay here because it's at the G junction. So we'll have to do a very dynamic assessment in such a case. Usually if there is a lesion in the stomach, you would see that the water is staying there, and you should be able to find out exactly where the lesion is originating from.
Dr. Hari, what you are planning to do in this case?
So basically, sir, this patient is asymptomatic. This was incidentally picked up subepithelial lesion. What I would be more interested in, now when I've done the primary screening, this seems to be originating from the second or the third layer. And for me, this is more likely to be a leiomyoma, but it could be a GIST. Okay, so if it's a leiomyoma, which we'll be able to only differentiate when we do a fine needle biopsy. If it's a leiomyoma, we can leave this lesion as it is. Because leiomyoma
will go for FNA now in this case?
We'll go for an FNA in this case to confirm what this is. First, I'm trying to see if I can show you all the layers of origin. Okay, so just unfreeze. Yeah, freeze. Again, unfreeze. Yeah, freeze. Okay, so here what is very clear is that the muscularis propria is intact. So this is the fourth layer. If you see from here top, the muscularis layer, propria layer, the fourth layer is intact, and this is the submucosal, the third layer.
Yes, very well appreciated.
So it is coming from the submucosal layer or something above that. Because it's a very small lesion, we might not be very clear on where it is coming from, but this is very important for me. For if the muscularis propria is intact, it is very likely that we should be able to remove this lesion by doing a stir technique. That is submucosal tunneling and excision, because we'll be having an intact muscularis propria in this case. Even if I'm not able to identify exactly what layer it is coming from, but this gives me a good impression that the muscularis propria is intact. And many times your US is not very specific or sensitive to find out the exact layers. Like in difficult locations or in small lesions, this is a problem. Okay, so with this, we'll like to now go ahead by doing a FNA from this lesion, and yeah.
So
so while doing an FNA,
you will be planning later on after the report of FNA.
Yes. So as I told you, if it's a leiomyoma, then this lesion can be left like it is, as it is. You don't have to do anything for this lesion. But if it's a GIST, it definitely has a malignant potential, and in such cases we would like this lesion to be out.
That's why you will wait for the report of FNA.
Yes, we'll wait for the report of the FNA. The only lesion, according to me, which is very clear, very evident on the US itself, where you don't even need to take a tissue, FNA or FNB, I'm talking about subepithelial lesions, is a lipoma. So lipoma is the only lesion which appears hyperechoic. You will see a clear hyperechoic lesion. So among all subepithelial lesions, if you see a hyperechoic lesion, you are dealing with a lipoma, and there you don't need to do anything. But if you see a hypoechoic lesion, you have to more often than not go in for tissue diagnosis. Yeah, can I have the FNA needle, please? So we'll be using the Olympus. Can you just the Easy Shot 3+ needle of the Olympus, and I'm just loading in the needle. Ideally, in subepithelial lesions, a FNB has a greater yield than a FNA. So if there is a possibility, you should always go in for a fine needle biopsy than a fine needle aspiration. Especially so this is a very small lesion, so we'll attempt that if we can get the tissue out of an FNA also. But if given a choice, a FNB might be much better than doing a FNA. So I'm just fixing the needle now. Yeah. Can you? Yes.
Yes.
Can you all see the sheath coming out? So the first important step here is to always make sure that the sheath has come out. Otherwise, you will just puncture the sheath, the inner sheath of the scope. So I think we are within the lesion here. Can you see the needle going well within the lesion?
Yeah. Very clear. Very clear.
Yes. So by repeated jabbing movements, we are taking tissue acquisition. We had already seen on a color flow that there is no vascularity here. Otherwise, if we had not done that, that should have been the first step. So because this lesion is very mobile, I try to change my scope position based on how the location is coming up, and after 4 or 5 jabs, I will now remove the needle and we'll see what tissue has been.
What is the size of the needle?
Sorry?
What is the gauge of the needle?
It's a 22 gauge FNA needle.
Okay.
So the system we are using here now, the Olympus has come up with a US ME3 system. So the ME3 gives us more advantages as compared to the previous ME2 scopes that we had. One of the distinct advantages is you can do a elastography. There is an elastography option by doing an US ME3, and also you have better image dynamics that you can acquire with this FNB. So do you have tissue? Can you just focus over here? Can you just focus on the camera over here?
Camera, kindly focus over the tissue. I think it's a good side tissue, and
so yeah, just can you hold this? Can anybody hold this? So whenever we take a tissue on an FNA, you take dry smears and you take alcohol fixed smears, and you also have the option of taking a cell block, right? A cell block works as good as doing a FNB. Can you see this tissue coming out? Is this visible?
yes, very much.
Yes.
Yeah, so you see a good tissue that has come out despite this being a small lesion. So with the US, you have the capability of approaching even small lesions, and acquiring a good amount of tissue by using your FNA or FNB needles. But as I said again, in subepithelial lesions, it is always better that we use a FNB rather than a FNA. So this is the slide. The alcohol, can you just open up the alcohol? So for the alcohol fixed smears, as soon as possible, as soon as you have prepared the smears, you immediately put it into the And for air dried smears, you don't have to rush so much. And apart from this, you should have a tongue-like projection, like proper cytology smear preparation. And apart from this, we would also like to take cell blocks. So cell blocks, we usually take it on a filter paper and we just put it into the alcohol. And do you have a filter paper here? Just get it. So this is what we have taken, and we'll repeat this. If there are any questions, I can answer that. Otherwise, we can shift to the next room.
Any questions from the audience?
Any differential of this hypolesion other than GIST and leiomyoma?
Yes.
So in this location, I am not very sure, but if this was in the stomach, neuroendocrine tumor would have been one of the differentials for me. But I would not expect a neuroendocrine tumor at this location. For me, in this location, I think it's 90-95% it's a GIST or a leiomyoma. I think some neurogenic tumors can present this way, but these are extremely rare and of no consequence.
Yes, sir.
If you are planning any procedure in this case, why you are doing FNA? It will produce lot of fibrosis.
Dr. Hari, there is one question from the audience. Can you hear me?
Yes.
They are saying that if you are not planning any intervention in this case, why you are going for FNAC? Because that will cause fibrosis there and subsequent surgery will be difficult.
So I agree, that's a very relevant question. But as I told you here, I suspect this could be a GIST. Now the patient will ask you a question, what is this lesion? Do I need to take it out or I don't need to take it out? So I have to give him an answer. So if it's a GIST, I'll tell him there is a malignant potential to this and this has to be out. If it's a leiomyoma, you can leave it as it is. If I was very certain on the imaging itself, I would not have gone on with the FNA. The other aspect here is that surgery, if you're talking about, in this case, we'll be planning to do a stir technique. For a stir technique, the scarring over the mucosa is not of any significant consequence. Because in the stir technique, you would be entering proximal to the lesion, maybe 2-3 centimeters, then creating a tunnel, going underneath the mucosa and dissecting this layer, this lesion from all the layers and then just bringing it out. So here scarring is not of significant consequence.
Thank you. Is that clear, sir?
Indication to remove such type of lesions.
What are the indications to remove such type of lesions? There is one more question from the audience.
If these are pre-malignant lesions, if the lesions are growing in size over a period of time, and obviously there would be a subset of patients who are very anxious about what this lesion could be and they would want it out. But I think the most important thing is pre-malignant lesions have to be out.
I just want to know with what complaint patient was admitted here.
This was an incidentally diagnosed lesion on a routine endoscopy. So obviously, if you have a symptomatic lesion, it has to be out anyhow. It has to be treated. If it were bleeding, if it was causing any obstruction, dysphagia, it would have been out. But this is an asymptomatic lesion. So here, the diagnostic, the need for therapy would depend on what this lesion is and on the patient's wish.
Okay, thank you. Any more question from the audience? Any more? So thank you, Dr. Hari, for your nice demonstration of EUS, and really it is well demonstrated. Thank you very much.
Thank you, sir.
What is next case? Yes, Dr. Jayant is there. Dr. Jayant is there. Dr. Ravish is there. I am seeing him. Ravish. Yes, Dr. Ravish, I am seeing you.
Yes, sir.
Yeah, very good afternoon.
Very good afternoon.
And really, it is for the first time in. I must congratulate all the people for organizer of this conference to conducting the workshop in this conference. This is being in Jharkhand. This is being done for the first time, and as we are more experienced, the things will be more and more better. So I must congratulate you and all the team. And what is the next case, by the way?
Yes, sir. I will be telling in next few seconds. What?
Cell block bana pe.
Welcome, Dr. Majid Aram Sahab. You have come, and I will request you to come over to the dais. You can.
Hello, Dr. R.R. Sinha.
Ayaz Satish, very good afternoon. How are you?
I think before if there are any talks, one or two talks you can take, then before the next case gets ready, we will just call you and let you know. Because are there any talks left or?
Yes, Dr. Satish, how much time it will take to go for another case?
It will take at least 10 to 15 minutes.
So in the meantime,
if there are any speakers, you can continue with it, and after that, we will call you or somebody will call you.
is Mr. Chetan Agarwal here? Financial planning for healthcare professionals. ये पहले
Okay, moving forward to the next speaker in between the live surgeries. We have Mr. Abhishek Agarwal sir, and we would like him to talk on the topic of financial planning for healthcare professionals.
Hi. A very good afternoon to you all, and thank you BJISGCON for giving us this opportunity. I'm Abhishek Kumar here from Edelweiss Asset Management, and I am here on behalf of the NJ channel, NJ India, who is into investments. So it is predominantly a very important thing for all the doctors, and they face generally this challenge that how they should actually do with respect to their financial planning. Because, at this point of time, you have n number of opportunities in the market to invest. But when it comes to actually having a proper advice, it always happens to be a big challenge. So with this context, we have a partner, which is Mr. Chetan Agarwal, associated with NJ Wealth. So he is managing around 250 crores of assets, and he has more than 1,500 clients. I'm here to represent him on behalf of Chetan Agarwal. These are some of the investment avenues that you have currently in the market, like when it comes to investments, Sukanya Samriddhi, or senior citizen, PPF, Kisan Vikas Patra, 5 years NSE. There are various opportunities, there are various tax exemptions, etc., which is there in the market. But the thing is that today not much of us are aware about investments into mutual funds. So these mutual funds have actually come up in a very big way, and it has actually created a very strong disruption in the economy. If you see, today almost 65 lakh crores of assets is in mutual fund industry. The industry is growing leaps and bounds in a very, very big way. And the kind of returns that has been generated in mutual funds are something which is very, very interesting and mind-boggling. These are some of the examples of bank FDs, etc., which is a general phenomenon for every individual to deploy money into. So, let it be a 1 year, 2 year or 3 year FD, this is the kind of return that you generate. But is this return really enough? Because what happens is that taxation actually plays a very vital role in this. So all of you coming into the highest tax slab, if you see 30% of this going into tax, you are left with a money which is not even, sufficing the inflation numbers. So on an average, if the inflation happens to be at 6%, the kind of returns that you are generating is not even matching that particular thing. So with that context, you have various categories of investments through mutual funds. You have all the parts into mutual fund. It is not only about equity market, but it is about equity, which is shares and debentures. You have debt schemes, you have hybrid schemes, you have some solution-oriented scheme for retired people who are old age people who needs income at a regular intervals. And you have some ETF investment opportunities also, which is like the gold exchange, gold funds, etc., in which you can invest upon. A very surprising fact for you all is that this is a gist of 39 diversified equity schemes returns in last 25 years. So a simple lump sum of rupees 1 lakh has given an amount of 67.5 lakhs as on date, which is an 18.35% CAGR returns. And a very small amount of just a 10,000 rupee SIP in last 25 years has actually made 4 crore rupees. So what is the kind of investment that you have done? In 1 year, you are deploying 1,20,000, 10 years, 12 lakhs, 20 years, 24 lakhs, and 30 lakh rupees. An investment of 30 lakh rupees is making a corpus of 4 crores. So this is the kind of power, this is the power of compounding which actually creates a significant impact in a customer's portfolio. So through this particular mode, you can really create wealth for your future. Here, with most of the retired individuals and professionals as well, it is important to see that how you can actually create a long-term regular income, right? So there is a terminology, like SIP is something which you all might be knowing, but there is a terminology which is called as SWP, Systematic Withdrawal Plan. These withdrawal plans are predominantly created and made in such a fashion where you can withdraw your money, and just like a pension or a salary, it will come on a fixed date to your account on a regular basis. So this facility is something it's a facility in mutual fund where you can get a fixed monthly income from your MF portfolio. The units that you accumulate on a monthly basis, it gets redeemed on a preset date. And once it is preset, you are getting this money on a regular interval on your bank account. So just an example for you all. If there is a monthly requirement of almost ₹1 lakh for you to take care of your regular investments, etc., your regular expenses, etc., all that you need is an investment value of 2 crores. So if you deploy this much money to generate a ₹1 lakh monthly income, just see what is the corpus that you actually create. So here I have shown some example of a regular income. If on a ₹1 lakh monthly requirement, the investment needed is around 1.5 crores, the value which does not depreciate, your corpus of 1.15 crores after 5 years happen to be 1.66 crores. And that also by giving you ₹1 lakh on a monthly basis. After 10 years, that 1.5 crore happens to be 1.89 crores. After 15 years, it happens to be 2.26 crores. And after the 20 years, the value is 2.85 crores. So this is the kind of returns that you can accumulate during a period of time by deploying money into mutual funds and doing SWP from it, that is systematic withdrawal plan. So here what you are getting is a regular income of ₹1 lakh or a ₹2 lakh that you can decide upon as per your necessity, and based on that you can actually deploy the money and you can see your principal amount also actually growing. So you won't be seeing that the principal is going to have any kind of depreciation in it, rather the principal is increasing and along with it you get a monthly income as well. So this SWP is having too much of safety because we deploy money not only into equity, but it is into a combination of equity plus debt, right? So these have high level of safety also. They have liquidity also. It gives regular income and the money gets appreciated as well, right? These hybrid products, as I told you, is a balance of equity and debt, which gives you growth and stability both. Right? We are also doing one event where a fund manager from Bombay is coming, Mr. Bhavesh Jain, who is from Edelweiss Asset Management, managing 40,000 crore at Capitol Hill on 12th of November, 6:30 p.m. Those who are interested to have further information for further inputs just from the horse's mouth, the fund manager itself, are welcome to attend this session. I am sure you are going to have a great time and you'll be having lots and lots of input as well. So keep note of the date. It is 12th of November, 6:30 p.m. at Hotel Capitol Hill. Thank you so much. Any questions?
That doctor has no time. How to do it?
Pardon, sir?
Doctor has no time. How to do it?
Yeah, so the doctor has no time. That's why there are advisors who are generally for this. So as mentioned, I am here from company on behalf of an advisor, Chetan Agarwal, who is associated with NJ India. The contact number of that person is there. You can contact him and then he is the person who can come to you, meet you and do the needful on your behalf. So there are certain intermediaries who do it. Right? Thank you so much.
Our next session will be by Dr. Ranjan Patel sir on the topic interventional radiology in portal hypertension. Already covered. So moving forward, I would like to invite our next speaker, Dr. Sanjay Mandal sir, for his talk on the topic surgery in chronic pancreatitis.
আমি ফোন করছি
As Dr. Sanjay Mandal sir is not among us right now, he will take some time, so we'll be continuing with the live workshop. So please join us for that.
नहीं जाएंगे अभी तो ये नहीं जय
শুধু চুনা লেগে গেল। কি চুনা জানিস, এই 4টা দিন হয়ে সাদেরকে বন্ধ হয়ে গেছে। কি বলবো থেকে আর এ ভাই, বাবাই তুমি কাকিমার সাথে কথা বলো। না না, তুই কাকিমার সাথে একটু কথা বলো, রিকোয়েস্ট হচ্ছে। আরে শোনো না, অনেকজনের পেমেন্ট হয়েছে বুঝছো, আর আমি পাইনি। थोड़ा सा लीजिए, थोड़ा सा लीजिए, थोड़ा सा और चाहिए। नींद आ रहा है, बैठे बैठे नींद आ रहा है। हेलो, देख रहा हूँ काटा तो देख। হ্যালো, কিছু জানা গেল দাদা? আচ্ছা, আমার ড্রাইভার কাল ফোন করেছিল, কালীঘাটে যে কাজ করেছে হচ্ছে, অনেকজন ড্রাইভার নিয়ে পেমেন্ট পেয়েছে, কালকে দিন পেয়েছে, আগের দিন। হ্যাঁ, বলছি পেমেন্ট ঢুকেছে, রিপ্লেসমেন্ট পেয়েছো? বলছি আমিও এখনও পাইনি, কিন্তু পেমেন্ট হয়েছে। তো ওর যা সাড়ে পেলেও ফোন করেছে, বলে না ওদের যে ড্রাইভার টাইভার পরিচিত হয় না, ওর যে পেমেন্ট পেয়েছে।
Dr. Ravish, Dr. Jayant. Anybody from OT? Yes,
Hello,
Ravish.
sir.
Yes, Ravish.
Just a delay of few more minutes. Patient is being shifted.
Just
Few
tell
more
me.
minutes, sir.
Just tell about patient.
There are two cases, sir. The cases in which I am assisting Dr. Kapil Sharma is a case of decompensated CLD, NAS related. The patient has index bleed two years back, and at that time glue was done for gastric varix, and there was a large gastric varix GOV1 F2. Now after 2 years, patient again rebleeded, and now patient is planned for US guided coil plus glue injection.
That's right. That's fine. How many times patients bled?
Index case was around 2 years back, sir, and this is the second time, and he bleeds massively whenever he bleeds.
So planning for glue as well as coiling.
Coiling, US guided, sir.
US guided. Okay, fine.
Okay, sir. This is Jayant from 41.
Yes, Jayant, tell me.
Yes, sir. This is another case, and the planning is for cholangioscopy guided biopsy.
What is the case? What is the history? Just a brief history, Jayant.
Yes, sir. This is a stricture of CVD. With previously ERCP was done and stent was put there, and now the plan is for a cholangioscopy guided biopsy. So patient.
What do you suspect? What is the cause of a stricture in this case?
Most probably we are suspecting cholangiocarcinoma.
That's right.
Yes, sir. So patient has already been intubated, sedated, and just within a few minutes we'll start it. Dr. Sanjeev will do this.
I am seeing Vikas also. Vikas, very good afternoon. Very good afternoon, Vikas.
How are you, sir?
Fine. Nice to see you back at Ranchi.
Same here, sir. So I was discussing with Jan. This patient is having lower end CVD stricture. My priority will be doing a EUS for lower end biliary obstruction. Mostly either they are carcinoma head of pancreas or they are cholangiocarcinoma. And lower end cholangiocarcinoma are mostly mass forming cholangiocarcinoma compared to hilar cholangial. So in hilar cholangio there can be infiltration without a mass formation. But lower end carcinoma mostly they form a mass lesion. So I usually go with the EUS in these patients. And if EUS is not showing any mass lesion, then we can go with the cholangio.
How you confirm the diagnosis of cholangiocarcinoma?
So one is on imaging. So first and foremost is a clinical history. If you have an elderly gentleman, progressive jaundice without pain, and CT showing a mass lesion either at the hilum or at the lower end. So until proved otherwise, I will take it as a cholangiocarcinoma, and I may refer patient for surgery also, keeping in mind it's a high probability of cholangiocarcinoma. On the other hand, if there are some benign indicator like young patient who are smoker, or if there are changes suggestive of autoimmune pancreatitis, if there is a diffusely bulky pancreas, or multifocal stricture in the intrahepatic biliary tree, or large necrotic nodes, I will think of benign etiology, especially in the alcoholic patients. So elderly patient without any risk factor for the benign disease, I will take it as a cholangio. If on CT scan there is a mass formation, I think it's a straightforward case for surgery. So what's your opinion, sir, on that?
When last ERCP was done in this patient?
So,
and at that time only stenting was done, or anything CRE balloon and any other thing has been done?
So, sir, there was stenting was done, sir. Stenting and brushing.
Brushing was done.
Only stenting and brushing you take. And we know that yield of brushing is only 30%.
Yeah. That is not very effective in diagnosing this thing.
And I think before we go for therapeutic ERCP, and it's essential to have a diagnosis actually. So either we should do a very good quality CT scan and US in lower end block. So I think these are two mandatory things, good quality CT and good quality EUS. If the patient is in cholangitis, you may go straight forward to the ERCP. But otherwise, I think I will go for try to clinch a diagnosis first before doing ERCP in these patients.
CT has been done in this patient?
Sir, I have limited information. CT, can we get CT? I don't have right now, so I will ask for it.
Because CT will give you much information in this patient.
Yeah. But that CT should also be done before doing ERCP.
That's right.
Sometimes there is mass at ampulla also, and once you cut the ampulla, you may not see a mass lesion.
That's. So you are planning for cholangioscopy in this patient?
Yeah. So lower end block, either it can be a ampullary tumor or it can be a CA head of pancreas, it can be a cholangiocarcinoma. I think these are the main differential diagnoses.
What is the level of jaundice in this patient? What is bilirubin level?
So I have asked for file. I just short history with me. So I am trying to get the file with the file. Please. I was just crossing by and you got hold of me. So I am glad to answer your question. I am asking for the file so that I can give you full history and the imaging findings. Can I get a file of this?
Yes, okay.
So, and I think in the file there will be more consent form than more clinical information. So earlier when we were studying, doing our DM in file, we used to have more of history and the investigation reports. Now in files there are more of academic administration work, more of consent forms.
Actually, because you see, the hospitals which are NAPH, they have got much work, written work other than.
So as you mentioned, sir, I can see a prescription, pancreatic head as well.
Pancreatic head as well.
So this bulky head of pancreas, dilated HBR, and we don't have information regarding PD. So if PD is non-dilated, it's unlikely to be pancreatic cancer. If it's only dilated CPD and it's a bulky head of pancreas. So two things, either it's an inflammatory mass. So I have to take history of alcohol, number one.
Inflammatory mass in head of the pancreas is also very rare actually. Hardly 1% you get now.
Alcoholic patients who are consuming alcohol or CCP with the head mass. So one possibility is the alcohol intake, inflammatory mass, and second is IgG for this autoimmune pancreatitis. So localized autoimmune pancreatitis involving the pancreatic head region. So I will keep these two possibilities.
By US, we'll get it clear. It will be clear by any US.
As I mentioned, I will prefer doing a US over the colonoscopy in this case. And rarely we have seen pancreatic tuberculosis also of the head, rarely, and pancreatic lymphoma also. So if you ask me order of the diagnosis, if PD is dilated, I think it's a straightforward CA head of pancreas. PD is normal, I will keep other possibilities of inflammatory mass, head of pancreas, then lymphoma, tuberculosis. These are my possibilities.
Okay, let us see. You start the case. Then.
So I think we will do cholangioscopy first. If it's not giving information, not giving much information, we will switch on to EUS in this case with the permission of organizers. Ampulla was bulky during the side view examination. On MRCP, abnormal smooth narrowing of terminal CBD causing gross dilatation of upstream biliary system and pancreas appears bulky with the surrounding inflammation, likely pancreatitis. So this is prior to CP. So there was some inflammation around the pancreatic head, cholelithiasis. So CBD dimension was 16 mm. with the smooth tapering. So I think diffusely bulky head and tail, smooth tapering of CBD, one possibility of autoimmune pancreatitis definitely there. Bilirubin level was 13 bilirubin.
That is not much. After
13 for a I think for a stone disease, there is gallbladder stone. So I think maybe just a sludge in the gallbladder due to so highest bilirubin was 21 actually, 21.
Is it not possible? It might be a benign stricture.
Sir, autoimmune pancreatitis, I think that's like benign etiology.
Yeah,
Pancreatitis.
I think benign stricture. You have keep that also in one.
So I have to see MRCP also. If on MRCP there is smooth stricture narrowing from all around. Yeah.
Before cholangioscopy, why you are not going for US first?
So I think we are getting a consensus of EUS first. So I think in the so I will take permission of JNCP. So yeah, I think yeah. So we'll do EUS, sir.
That
so
I
as
think
you
also.
said, yeah. There is cutoff actually on MRCP. There is a cutoff of. So can you see MRCP image?
No, not visible. Now it is, but not very clear.
So we can see that. So what you can see on MRCP. So cystic duct is joining the main CPD. Then in the intrapancreatic part, there is sudden narrowing of the duct, sudden cutoff of the pancreatic duct. So, and here you can see, can you see here? It's a smooth narrowing here actually. And it appears that it's compressed from both the sides. So I think it seems that the CBD is compressed from both the sides. As it getting compressed in the pancreatic head from the 360 degree.
Might be pancreatic mass.
Sir, I think if it's a pancreatic mass, it should compress from one side and push it to other side. If you see the stricture, it's in the central part of the expected course of CBD. So this is course of CBD. If it's a pancreatic mass, it should compress from either this side or this side. But the stricture is in the center of the expected path of CBD. I think it's a compress from this side and this side both. I may be wrong. So you can see here. So mass will compress from one side actually. I think this is case for sir EUS first, no doubt. And let's see, try to see pancreas also. So what do you think based on this MRCP? Yeah, PD is not dilated. We can see PD there, it's not dilated. And it's a bulky pancreas.
No significance bulky pancreas.
Here, I think here, yeah, this is the pancreatic head. Can you see that? This is the pancreatic head.
Still, I will go for, with pancreatic mass.
Yeah, definitely, sir.
Yes, I will go with pancreatic mass.
Head of pancreas, something is there. So, we'll do ES, sir. ES will clarify the things. So, IgG4 is awaited. But in CA, head of pancreas, MPD should dilate until unless it's a mass of uncinate process. So I think, sir, in lower end CBD block, CT angiography should be investigation of choice. CT angio or MR angio. MRCP gives limited information in a patient with the lower end CBD block. So if the patient comes to me, I will do CT angio first. If ultrasound showing lower end CBD block, a suspected malignancy, I will go with the CT angio. Because I am more comfortable reading CT angio as compared to MR angio.
You will get every information in the US.
Hopefully, sir. No. I think if the stent in situ, it doesn't make a difference. We don't remove stent prior to. So, if the patient has come directly to us without ERCP, we will do EUS first, decide resectable lesion, go for surgery. Unresectable lesion, we will do ERCP followed by chemotherapy. Now, even for resectable lesion, when you have CCA99 more than 1,000, surgeons want neoadjuvant chemotherapy and neoadjuvant chemotherapy. So most, yes, sir.
When you are going to start? It will take another 10 minutes or 15 minutes?
So the hero has come, sir. Sanjeev has come. So we will do it. So Sanjeev, there is a change in plan actually. So this patient has lower end CBD block with the bulky head of pancreas. So earlier plan was to do cholangioscopy, but now there is a consensus that that we should go with the EUS, endoscopic ultrasound. So
Should I do cholangioscopy first?
no, there is a instruction and.
Or you just tell
No, you people should decide what to do first.
change the sequence.
Okay. Then we do cholangioscopy first. Yeah.
Even CBD stent is already in place.
Okay.
So anyway, I can going to place the stent again.
Yes. Okay. So there are so we'll do cholangioscopy first. If that gives us enough information, then fine. If still in dilemma, we will do EUS.
Gloves, sir. Gloves. Patient left lateral position. Seven and a half. Take close to my vision.
Hello. I think we are ready with the case. Am I audible there?
Yeah.
Okay, sir. Now, as I already told about the case, this is a case of decompensated CLD with GOB1, and we are planning for US guided coil and glue injection. And
myself is Dr. Kapil Kumar Sharma. I am a gastroenterologist, and I first would like to extend my sincere thanks to Team GastroCon Ranchi for giving me this opportunity, especially to Dr. Jayant Ghosh. You must have heard this history. I will narrate again. Patient had a chronic liver disease which is NASH related, and patient has bled 2 years back, and he already injected 5 ml of glue. Now the patient again re-bleed, and here you can see the large gastric varices. Why these gastric varices form? Gastric varices form to decompress the portal hypertension, and because they form in the submucosa. Once they are varices, there is two channels. One is afferent, one is efferent. The afferent call as a feeder. Efferent most of the time is a shunt, maybe gastrorenal shunt and sometimes gastrocaval shunt. So most of the afferent in the gastric varices, either you look for the left gastric varices and short gastric varices, and rarely you can see the posterior gastric varices. Instead of shunt, sometimes these gastric varices empty into the various collaterals, and then hence once you are dealing with the large gastric varices, always look for the shunt. The shunt make a treatment. Then you also involve your IR people. They can also do some kind of BRTO if shunt is very large. I will demonstrate this gastric varices. Once you want to see the gastric varices, you need to put a water in the lumen. Then you can identify whether this is the intragastric varices or perigastric varices. Intragastric varices lie within the second layer of wall of the stomach wall. Now we'll suck the air and we'll inject the water. Here you can see there is a large amount of air. First we'll decompress the air and then we'll inject large amount of fluid, and then we can easily identify the gastric varices. Regarding the classification of gastric varices, regarding it may be if there is an associated esophageal varices, it the GOV1 or V2. If there is a lesser curvature, it is GOV1. On the greater curvature, then it is GOV2. If isolated gastric varices, they called as a IGV1 and IGV2. This is the serine classification. Now you can see the water is coming out, and you can see the there is an anechoic structure in the wall of the stomach, and you can nicely here see. First, we will try to identify the afferent and efferent. Here you can see this gastric varices exactly open the shunt. You can follow this shunt. This is the shunt. And if I will like to trace it down, trace it down. Here you can see this is near this is the aorta. This is the aorta and this is the shunt. Once you have a large, they usually cross through the nearby the aorta into the gastrorenal vein to left renal vein into the kidney, and then subsequently we go to the systemic circulation. There are always chances of embolization of coil and glue once you directly do without. And now our job to identify what is the feeder and afferent. Feeder mostly come toward the spleen, and then you have to look from the lower part of the gastric varices. Here you will find a feeder. Now you can see there is some kind of short gastric vein. Here you can see this might be a short gastric vein feeder, but these varices can be fed from two afferent. Hence you have to always look for the left gastric vein. Left gastric vein can be seen near the splenic confluence. You can first see, you have to little bit push, and then you can go. These are the gastric. Nicely you can see these are the gastric varices. And this is the short gastric vein. And what you can do, sometimes you can apply the Doppler. And once you apply the Doppler, you need to increase the velocity. You have to remove the power Doppler. Yeah. Yeah. Now you can see the spleen. Any question, any opinion regarding the from the chairperson and the expert regarding the modality of treatment? Now you can nicely see the gastric varices, which is arising from the third layer, and you can nicely see the shunt. This is the shunt.
Very well appreciated. Very well appreciated. Are you still planning to go for glue and coiling?
Yeah, we will inject a coil first, because coil will keep the glue in situ into the gastric varices. They decrease the chances of the glue embolization, because the glue, if you inject alone, it can embolize easily into this shunt, and sometimes patient can develop a pulmonary embolism. The two complications that should be looked once you are treating these gastric varices, first is the bleeding and another is the embolization.
Do you think one coil will suffice in this patient?
I think that it might be two at least two or
I think so. I think
Now you can see, we want to look for the left gastric varices also, because at some time you find two feeder. One is from the short gastric vein, another from the left gastric vein. To find, I think this is the feeder. Where is the cursor? Yeah. This is the feeder. Here you can see this is the spleen. The short gastric arising from the spleen, and it is feeding the varices.
Yes.
The problem is there, we are very close to the shunt. This is shunt. This is shunt. Yes. Large shunt. We can measure the size of, we can load the coil. What do you want? You want me to block the feeder, or you want me to inject into intravesical component of these gastric varices? What is the opinion from house and the chairperson?
Any opinion from the house? Any opinion from the house?
Block the feeders.
Yes, one. Block the feeder first.
Dr. Vikas. We will measure the size of.
Sir, Dr. Vikas here.
Yeah, Dr. Vikas, what do you think? And we have find the feeder, and we have find the gastric component of the varice, and we have a large shunt. So we should block the feeder, or we should block the.
Yeah, I think we should try feeder first.
Yeah.
So if you're getting a proper window, I will try injecting first in feeder.
Here you can. I will demonstrate. I think this is the feeder, short gastric vein, and this feeding is this component of the gastric varices. It will inject a coil directly here and block at this part, and then we are able to manage this gastric varices, because above you can see that there is a shunt. Do you agree with me?
So in the lower part we are seeing spleen. This is spleen.
This is spleen.
Yeah. So we can see. Are we getting a window to inject the efferent directly without traversing through the vein?
No, the shunt is coming in our window. You can see this is the shunt, but we will try to manage from. We will inject a water.
Pani. To be part of the varix which is closest to efferent, we can target.
Yeah, totally agree. We can also measure. If we can target this area.
Yeah, so I think this part we can target first.
Yeah. First we'll try to inject, but I think that we are traversing to the shunt. Let me see.
Yeah, that's not an issue, I think.
That will not be issue.
So when you are injecting a varix, you have to inject in the distal mode part first.
Yeah.
Because if you inject proximally, then you cannot approach the distal part.
Definitely, totally agree. Then we can withdraw the needle. And now we have a technician.
So can we see continuity of that?
Vinay.
So can we see the continuity of varix with the splenic vein or the splenic?
Yeah, I will show you. Here you can see this is the splenic vein going in.
Can we have Boston needle here? No,
Now we'll inject coil. Coil is already loaded in the.
So we can show them how to load a coil.
Yeah, that is the most important part.
We can bring
your technician should be trained in how to load a needle. That is the most important part. Yeah, please.
So size of coil is 12 mm or what? 16?
We will first inject 16 mm. The size of coil should be decided. That if we should measure the conglomerate diameter.
So can you see coil here?
Can you magnify that, Vikas?
Yeah.
To be more clear.
So Can you see dimensions?
Can you make it big screen, on big screen?
Yeah. So there are 3 dimensions. So we can see 35, 14 and 16. So 35 is the thickness of wire, like 035 wire. So we have 2 coil, 18 and 35. Similarly, we have wire 035. So this is the diameter of wire 35. So we need a 19G needle for this. 18 can be passed through 22G needle. So the 35 diameter of wire. Then 14 is the length of the wire. Length of total wire 14 centimeter. And we have 2 lengths 7 and 14 mm. So here we are using large bearings 14 centimeter wire. And 16 is the diameter of the coil. So once there is a loop formation, 16 is the size of loop. Am I clear?
Yes. Any questions from the audience? Any question?
Slowly. So now we are loading the. So we will load the coil. So show them the coil. So you can see a protective wire. This is the sheath. Inside the sheath is the coil, and the length of coil is 14 centimeter. And there is a protective wire. So first we will unsheath it. Then we will remove the wire. This show them. Yeah. Can you see that? We are removing the wire from both the ends. Now we have remove the sheath. Yeah. Now you attach it. Are you able to appreciate?
Can you magnify the picture a bit, or you can make it full screen? Is it not possible?
So are you able to see?
No, actually we are not.
इसको चेंज करो, इंटरचेंज करवा दो इसको ना, इसको दिखाओ, ये अटैचमेंट निकाल दो, ये निकाल बाहर निकाल दो. So this is the sheath. दिखाओ, ये यहाँ लग इधर. So that's the sheath with the wire. Can you appreciate that? So this is the sheath with the coil inside, and there is a lock. We will attach a lock on this, and now we will fix it over the needle. Now can you appreciate?
Yes.
Now with the stylet, we will push the coil inside. So now we have pushed the coil inside the more you can put more. Yes, that was the other. So now the coil is, we have pushed the coil inside the needle. Now we'll remove the sheath.
हो जाएगा पेशेंट को. Because, can you describe the lesion? To me, it looks benign, smooth.
So now, can you see us?
So we have shifted to this cholangioscopy session.
Yes. Go inside.
And no need for fluoro. No need of fluoro.
So now, Dr. Rajiv, you can see that now we have gone inside, and that's likely the cystic duct at 5 o'clock.
Yeah. Very well appreciated. Yes.
And above is the common bile duct, and there is no narrowing in this area. We can go higher up also, and we can see.
I'm going towards the hilum.
Yeah.
Yes.
Plus. Yeah, go inside.
Yes, we are seeing the both ducts.
appears normal.
Yes.
We have reached up to the high level.
Yeah.
Yes.
So
yes.
still normal mucosa.
Yeah.
It is not
So, benign stricture, I can take
Yeah,
couple of while.
looks like benign stricture.
So is it, sir, stricture or it's a circumferential compression from outside? Now that's the question now.
That's why I told you to go for EUS.
That's why you need to do EUS.
So because 23 bilirubin and yeah.
Now we are like
Just at the strictured area.
now we are ready with the coil, sir.
Just a minute. We are in OT, other OT for gastric varices.
Are we on?
Yes, yes, sir.
Can you hear us? Now you can see the tip of our needle at the pointer.
Yes.
There you can
Yes.
tip of. I already measured the length, and it should not overshoot. And we are trying to target the most distal part, and that should be fed by the short gastric vein. And then if you target that part, then come proximally and try to obliterate whole component. So now first I will puncture, then my assistant will deploy the coil, first coil, then second coil, then we will inject a coil, glue. Now we are ready with puncture. Inject. Now we are inside the gastric varices.
Coil has not been injected till.
Yeah. Now you can see the coil is coming slowly. The few air bubble.
Yes.
First.
Yes. Yes.
And now you can see the coil is coming.
Yes. Yes. Yes.
Coil nicely deployed. Then we'll inject another coil. First we'll flush with the dextrose.
Yes. One coil has been deployed now.
Yeah, we will inject another coil.
I think this varix will require multiple coils, 4 or 5 coils.
We will inject 2 and then subsequently 2 ml of glue. What do you think, though? First you flush.
ग्लू रेडी कर लो इसमें.
Now you can see. Yeah. We are pushing another coil.
I think we can slightly torque on the anti-clockwise side. No, other side.
Which glue you are using?
Cyanoacrylate.
Cyanoacrylate.
Which is the there. Yeah. Now you can see this second coil come. Then I will move the needle slightly proximal. And I think that this coil has been also been deployed. Now we'll inject it 2 ml of.
Go full. पूरा जाओ ना अंदर.
Oh, completely deployed. It should be deployed complete.
Yeah, complete.
Yeah, complete. Complete.
Yeah, go inside.
Yeah,
Yes.
Now we'll just.
How you assess amount of glue to be injected?
We should have a complete oblation. There should be cast formation, and you can also see the acoustic shadow. First flush.
So maybe, sir, in the aliquot of 1 or 2 ml, there is no definite rule. So in a aliquot of 1 or, I think this is large varix, we have decided for 2 ml in this varix. Can we inject 2 together? Okay.
Slowly.
दो इकट्ठा दो ना फिर.
Yeah. Yes. Yeah. Now you can see we are getting a cast.
Inject.
Flush. Low. We can push the sheet. Now we'll come out because very essential to save the scope. We have to flush. Please let's go with the acetone.
So can we have one more coil, one more needle?
Yeah. First inject from the channel, otherwise channel will block. Inject the channel through the.
So we have injected 1 ml of glue inside the varix, but I think a needle is getting blocked. So we'll use another needle.
You will inject 1 more ml.
1 more ml, yeah.
Yeah.
Needle is blocked.
I think that's the issue. Actually, we have N-butyl cyanoacrylate and N-octyl cyanoacrylate. In India, we have N-butyl cyanoacrylate that has a very short time of polymerization. It immediately polymerizes.
Yes, immediately polymerize. That's why.
Ideally,
that's why I asked you what are the types of glue.
Sir, in India we have butyl only. We don't have octyl actually.
Okay.
Octyl has a longer polymerization with the lesser risk of needle clogging, but then it increases the risk of embolization. I think we can mix it with the lipoidol. That increases the time of polymerization.
Otherwise, needle will be blocked. You can damage the scope also.
Yes. I think we have to inject more.
Yeah, we have to inject more. I think we have most distal part as patent, and
so can we have needle here? Oh. So इसको साफ करो, इसको साफ करके देखो. So we had only one needle, so we will use the gastroscope and we'll do conventional glue injection now.
That's good. People will see also that. Conventional glue.
So actually, sir, I will quote a study by Sohendra's group in 2010. So they gave it a name of standardized regime for glue varicose injection, gastric varicose injection. Excellent study. If I remember correctly, 150 patients. So what they did, they injected glue 1 ml at multiple sites. So if you follow that policy that injected 1 ml during each injection, you can go up to 10 ml also. So that are found to be a safe technique. So what they did, they mixed N-butyl cyanoacrylate with the lipoidol and they injected in a liquid of 1 ml and they probed each part of varix and they performed a complete obliteration of varix during first session. So sometimes what happens in a large varix, we inject a certain area, we don't inject the whole varix. That's a common mistake we make and that leads to increased chance of rebleeding. So whenever we are doing endotherapy of gastric varix, even by conventional technique, whole varix should be oblated during the first session. So we can go up to 10 ml, 15 ml, that doesn't make any difference.
Is there any side effect of using that much of glue?
Sir, if
is there any study on that?
Sir, that study mentioned if you inject 1 ml each time, so don't inject more than 1 ml. If you inject 1 ml each time, there is hardly any risk of embolization. If you inject in larger liquid of 2 ml, 3 ml, so don't inject 3 ml altogether. Inject 1 ml at one side, go to other side, inject 1 ml. So 1 ml injection, multiple sites performed. So I follow that policy in my practice. So I inject multiple sites and try to obliterate whole varix during one session only.
You are not using coiling in that?
No, coiling we cannot. We also do coiling also. So if you ask me, I don't think there is any difference between the gastroscope guided injection or EUS guided injection. No study till date has proven that EUS guided endotherapy is better than the standard technique, provided you inject each part of the varix 1 ml in each part. So you have to obliterate whole varix by a liquid of 1 ml at multiple sites. That should be policy.
Okay, so welcome back to OT1, and
Yes,
Sanjeev sir is already on the way to take biopsy by cholangioscope. And
Plus? Plus?
So Sanjeev sir, right now what are you doing, sir?
The structure looked smooth and benign, but still we are taking biopsies.
Yes.
We have taken 2 bites. I'll take the final bite now. I push the spy bite forceps inside the bile duct. My assistant will open it now. I'll capture the tissue, cut, and it's done.
Jayant, Dr. Jayant, what is the plan now? After taking biopsy, what he is going to do now?
I'll place the stent.
Okay,
because, yes, because I have been
Placing a 7 centimeter straight stent. We are placing 7 centimeter straight stent, and then we'll do EUS for this patient.
There is no need to go for dilatation or using CRE balloon in this patient.
Sir, I don't think it's benign. So we don't have diagnosis here actually. We don't know the diagnosis.
It looks like if it looks like benign, then why not you can go for that dilatation with CRE balloon? And then
what is the purpose of dilatation?
So if it's we have to, I think, establish etiology first. What's the etiology in this patient? So if the patient is post-cholecystectomy, in those cases we follow a schedule of multiple stenting, or the patient has chronic pancreatitis with the CVD stricture. We follow the schedule. So still I think we are not sure about the cause of the stricture. Sanjeev, what's your opinion? What do you think is the cause of the stricture?
If this is a benign biliary stricture due to benign pancreatic lesion, then if you do dilate, it is again going to recur. So better to place long-term stent.
So if it's so I think if it's a chronic pancreatitis, then we can follow a schedule as suggested by Costa Maina, where we place multiple stents, and I think the efficacy around 30% with the plastic stent. But if it's an autoimmune pancreatitis, I think single stent giving a course of steroids, I think should suffice.
इधर हमारे पीवीडी में भूल गया कोलेंजियोस्कोप.
Dr. Sanjeev, if it's a benign lesion, why and you think it to be a pancreatic origin? Is it due to pancreatitis?
Frankly speaking, I don't know the details of this patient.
Okay. In that case, we can use covered stent. That would be a better choice than a plastic stent.
Yeah, fully covered metal stent.
Exactly.
But the risk of complication is there. So
I agree with Dr. Vikas. Unless we have a firm diagnosis, plastic versus fully covered, steroid versus conservative, I think we should wait a bit. Once we have a confirmation of diagnosis, then only we should plan. For the time being, for decompression, plastic can do, but definitely diagnosis, final diagnosis will give us the answer.
We are going to do EUS now, and we will wait for the biopsy report as well. Then we will take a final decision.
Okay.
Okay, यहाँ का काम खत्म हो गया. Can shift to another room.
Can plastic stent distort your image during US?
It can cause some artifact.
Should US be done prior to inserting the stent, or either way we can go ahead?
It's better to do EUS first if you are planning to do EUS. But anyway, the plastic.
Okay.
Dr. Sanjeev?
Yeah.
Many companies coming with the AI in the cholangioscope. Is it useful to AI here? to give the diagnosis of a malignant versus a benign stricture.
Yes.
Ready? Okay, Abhi. Now you can see.
Dr. Rajiv, can you see us?
Yeah, you can see.
Now we inside the gastric varices, try to inject a.
So we are using
Flush.
another needle and we are.
Flush. Yes.
Hold on.
And then inject a glue.
Yes.
Flush.
Full karo.
Yes, glue has been injected.
Yeah. Flush.
Scope. Go inside.
Flush. Glue ready, huh? फ्लश में दिन तो ठीक है ब्लॉक फ्लश कर ग्लू नहीं है और क्या ग्लू नहीं है ना देखिए
Yes, thank you very much. Very nice demonstration and big clap.
Thank you, sir. Thank you.
हैं एक बार एंडो करके देखना हाँ ग्लू नहीं है ना ग्लू नहीं एक बार रुको आप हाँ ग्लू है ग्लू बाहर आ गया हूँ दिखता था तो मंगाओ यार ये थोड़ी कर रहा हूँ मैं इसको भी करके
It has been done?
Yeah.
Vikas?
I think
large part of the varix. There is still some part of the varix which is still having flow.
So you are planning for conventional glue injection in that?
We'll go inside and prepare the varix. Maybe we can inject more inside.
By conventional method?
Yes.
Not by US through?
Sir, we don't have needles actually.
Oh. Okay, thank you very much. And
Sir, we will show you. If you stay with us, we'll show you the endoscopy findings.
And by the time cholangioscopy has been done, and what is their finding there?
Sir, cholangioscopy is showing a benign stricture at the lower end.
Now you are going for EUS in that patient.
Yes, so it will be done in this room only once we are finished with the varix.
Acha.
And we'll take ecclesia cardiac case in other room.
You are taking ecclesia cardiac?
Yes, sir. We'll do one poem after this. So.
There is not there.
So CO2 has CO2 also.
There is standby.
So CO2 है.
কি আছে
CO2 है.
ব্ল্যাক হয়ে গেছে তো দেখো তো যাচ্ছে না লাইভ যাচ্ছে না
কিন্তু ওখানে যাচ্ছে না
যাচ্ছে
দেওয়া আছে
খুলে রাখো
তুলতে দেয়নি তাহলে
আমি দেখতে পাচ্ছি না তোমার
So we can see the
Yeah.
Now you can see that there is no activity. Now you can see the some kind of blue cast.
না আবার চলে গেল কি করে
ওখানে দেখুন না ফুল লাগে
ওখান থেকে যাচ্ছে কি না যাচ্ছে না এইচডি করা আছে তো
হ্যাঁ
তখন তো খুলতো না খুলো না ওটা ওকে আছে
So this is GOV2 actually. GOV2 you could continue with it. What I give you.
You can see the cast actually.
Yeah. Yes, sir. So we can do probing of this part, na?
এই তো এসডি আউট করা আছে
Maxi forceps even the band pusher.
अरे वो ब्लू आ गया
है ना
एसडी आउट করা এই তো
ठीक है
सिलेक्ट एसडी आउट
मंगवा रहे हैं सर अभी
बोलो
So I think patient is lying in the supine position.
We can turn it
So either we have a left lateral or the right lateral position.
to make this clot away from our gastric varices.
কত দূর হবে এটা
We can turn it left lateral.
तो घुमा दो
सामने कर देते
একটা প্যান্ডেলে
turn the patient to left lateral.
হ্যাঁ আমি এখন তিনটে ওটা আমি চাচ্ছি যেখানে লাইটটা গাড়ি গাড়িগুলো আছে হ্যাঁ
Now you can see this clot is away from our gastric varices. We have turned the patient to the left lateral. Now we'll probe this.
यूट्यूब में जा रहा है ना अच्छा यूट्यूब में है अरे
There is a lot of indications for intervention in chronic pancreatitis. However, intractable pain is the most common, and it is not without its controversies. For example, enzyme replacement as a modality for pain relief. Then the concept of wait and watch for the chronic pancreatitis to burn out. This is very controversial, doubtful whether it at all occurs, and the time duration of this burnout takes a lot of time. Patients may continue to have pain for a long time. So the moot point arises as what sort of intervention should we do and when should we intervene for pancreatitis, for pain in pancreatitis. Now traditionally it has been taught that you should go in a step-up manner, start with NSAIDs, then go on to mild opioids, strong opioids, endotherapy, and finally when everything fails, go into surgery. But there's a lot of literature which has now been available which shows that it may not be the best procedure, and a bypass to direct endotherapy or surgery may in fact have a good outcome. So when you go into the literature, you see a lot of this comparison between endotherapy and surgery. Overall, what initially emerged is that most of the studies showed that outcome with surgery was better with regards to long-term pain relief. And when you look at the very recent ESCAPE trial, which everybody talks about, you will see that in this, they did endoscopy first, compared it in a randomized trial with early surgery. And they found that the ISBC pain scores for chronic pancreatitis for patients post-operatively were much better in the surgical group. The short-term and the long-term overall pain relief was also much better. Now, if we look at the meta-analysis with regards to the randomized trials which are available in literature, you will find that pain relief overall and subgroup analysis shows better relief in the surgical group of patients than in the endotherapy patients. However, exocrine insufficiency and endocrine insufficiency was probably worse off in the surgical group compared to that, but probably not statistically significant. When we look at the reasons for failure of endotherapy, you will see that at times you have a lot of strictures, excessive stone load throughout the duct, which at times is not possible to clear on endoscopy. Then the question of the parenchymal hypertension, which cannot be dealt with by endotherapy, and of course stent-related duct damage changes are there, and that you may have a head mass. Head mass is a pacemaker of pain, and it is the reason why the pain occurs. This head mass cannot be tackled with endotherapy and has to be tackled surgically. And of course the central and peripheral neural sensitization of pain. So surgically we have options which are: one, resection procedures, in which Whipple surgery is the most common done. In drainage you have lateral pancreaticojejunostomy, and in the combined procedures you have what you call resection with drainage, which is the Fraze and Beggar's procedure. I won't talk about the total pancreatectomy with islet cell autotransplantation. So if you have patients like this where there's a large head mass, you have calcifications, these are patients ideally suited for surgery, and if you're thinking that they might have an underlying malignancy, then Whipple's is the surgery to do in them. You must understand that Whipple's is a morbid procedure. However, in spite of pancreatitis patients having a difficult resection, the pancreas is very hard and firm, the sutures hold well, and this pancreaticojejunal anastomosis, which is actually the Achilles heel of Whipple's procedure, is fairly well done in this, and the leak rates are less, and the outcome is quite good compared to patients in which we do for malignancies. The other procedure I talked about is the Fraze procedure, which is very commonly done, in which mainly the coring of the head is done and the pancreatic duct is laid open and it is anastomosed with the the jejunum. Now, very important to note that when you core out the head, you need to take out the whole of the pancreatic tissue of the head, not just the pancreatic tissue anterior to the head, which is done in most cases. So this classical Fraze procedure, in which complete head coring is done, which involves taking out this amount of tissue, is absolutely necessary to achieve good pain relief. For surgeons, the other important thing is localizing the duct. And previously it used to be recommended that you should have a dilated pancreatic duct when you're operating these patients. And you aspirate the duct, localize the duct and lay it open. However, if you don't find the duct, you have a lot of things to do. But nowadays what we have realized is that you don't need to look for the duct. You just core out the head and you will find the duct in the head region and you go retrograde. So it is not mandatory that you have a dilated duct. Even in undilated systems where we have 3, 4, 5 millimeter ducts, we can go ahead and do a Fraze procedure. Now, if we look at literature with regards to the surgery, I'm talking about Whipple's on one side and Frey's and Beggar's procedure on the other side, which is the head coring procedures and head resection procedures where you preserve the duodenum. You will find that Whipple's has more operating time, more blood loss, and longer hospital stay. However, when you look at the pain relief, you will find that all three give equal pain relief. These are randomized trials which have compared head preserving, duodenum preserving procedures with Whipple's, Frey's independently with Whipple's, and compared Frey's and Beggar's together. You find that pain relief is similar in all of them. However, in the duodenum preserving procedures, the long-term quality of life and the short-term quality of life is much better than in Whipple's. And when we compare Frey's and Beggar's together, you'll find there's not much difference in this. But from the surgical point of view, what we surgeons feel is that Frey's is probably an easier procedure to do, a Beggar's is a more difficult, and that is why probably world over and more often in India, we do Frey's more often. I have put two pain series. One is from GB Pant Hospital, Dr. Adarsh Chaudhary's group, and one from Dr. Sukant Roy from SSK in Kolkata, where he's done significant work on chronic pancreatitis, and I have put a bit of our old data there. Now, if you look at this, short-term pain relief is 90 to 100% and 75 to 85% long-term pain relief, which is phenomenal in most, and that's what we find if we do a proper Frey's procedure in these patients. But it's not that patients do not fail after surgery, and the most important reason of failure after surgery is when you have done an inadequate head coring. I had said that you need to core out the head totally, but if you do not core out the head properly, you're going to have patients who come back with pain. Also, if all the strictures have not laid open, all the stones have not taken out, these patients are going to come back with pain. Patients who have had post-operative complications may have more problems long-term, and patients may develop newer problems like biliary stricture, duodenal stricture, malignancy, and of course they may continue to drink alcohol. Also, if surgery was done late in the disease, patients who have become opioid dependent, multiple endotherapy sessions, these are the patients who do worse. Now, important fact is that when we are dealing with head mass, we have to understand if there is an underlying or suspected malignancy. And there have been a lot of criteria which has laid down to point towards malignancy. You have age, persistently rising bilirubin, evidence of duodenal obstruction, worsening of abdominal pain, weight loss, diabetes, sudden worsening. These cannot be taken on a single point, but have to be taken together. The whole picture has to be seen together. There have been also CA99 levels, cutoffs given, which may indicate towards malignancy, but you have to remember that CA99 is also raised in case of chronic pancreatitis, and also in patients who have jaundice in chronic pancreatitis, the CA99 is raised. You stent these patients and the CA99 simply goes down. So it's not because of the malignancy. CT-wise, the absence of duct penetrating sign. In other words, if you have an abrupt cutoff of the pancreatic duct or an abrupt cutoff of the bile duct, it indicates a malignancy. Mass with differential enhancement compared to the rest of the pancreas again may indicate a malignancy. And obviously, if you do an EUS and you get a positive biopsy on FNA, then obviously your diagnosis is clear. Intraoperatively for surgeons, if you find a hard pancreas, hard mass, vascular invasion, adjacent organ invasion, these are not exactly indicative of malignancy. And because it's very difficult to discern a malignancy, a lot of people recommend that when you're doing a Frey's procedure, you should send these for frozen section. But interpreting a frozen section on a background of chronic pancreatitis is very difficult, and we have seen reports go both ways. Patients who do not have malignancy being reported as malignant on frozen, patients who have malignancy being reported as benign. So the ideal thing is that if you have a doubt, you should do a Whipple's. In other words, you should do a resection in all these patients. When should we consider for surgical biliary drainage? Well, yes, patients who are jaundiced and who have other indications for intervention for chronic pancreatitis. In other words, they have intractable pain, head mass, dilated duct, multiple stones. These should all go for surgery. Obviously, if you have a doubt of malignancy, again, they should go for surgery. And if you have a doubt of malignancy, Whipple's is the procedure to do. If there's no doubt of malignancy, then Frey's with the hepaticogeneostomy is what is done. I keep showing this. This is a patient of mine I had operated long back from Mizoram. He underwent a Frey's, had very good outcome, was pain-free, but he never liked the scar because post-operatively he had a bad infection, he had a grotesque scar, and he put a weird tattoo on this scar. So this brings us to the question of why not do minimally invasive surgery in Frey's? We do laparoscopy for everything. For surgeons, if you understand that is the head mass, you have the duodenum here. phrase procedure or head coring is essentially a sort of blind procedure. And the left hand of the surgeon, which you see is behind the head of the pancreas, actually guides the surgeon to the extent of head coring. Otherwise, you end up going through and damaging the whole of the pancreas. It is because this is such a blind procedure and need the help of the left hand, it is difficult to do in minimally invasive surgery because you do not have that guidance of the left hand in minimally invasive surgery. That is why the data you see in the literature is that very few studies done, very few number of cases, and most of the time the procedure done was not a classical phrase and just a modified phrase. In fact, my good friend Kalai from JIPMER actually says that if you want to do minimally invasive surgery in chronic pancreatitis, you should either do a Beggars procedure or robotic Beggars or a lap Beggars or a Whipple's resection, not a phrase. So with this, my conclusion is that you should consider for early surgery in chronic pancreatitis patients who are otherwise indicated. Head coring and head resections are the procedures to be done. They give good long-term pain relief and good quality of life. The duodenum preserving procedures like the phrase have less morbidity, good pain relief, and better quality of outcome. Very low mortality seen in most series. A lot of series will report 0% mortality in this. With this, I'd like to thank you all for a patient listening. And we have a IHPBA conference next year in March. It's the national conference, and I would like to invite you all for those who are interested in that. Thank you. I'd be happy to take any questions. Yeah.
Nice talk. And pain
Thank you.
is not, I think, the only complication associated with chronic pancreatitis. As pain is not the only problem with patients with chronic pancreatitis. Regarding exocrine insufficiency and endocrine insufficiency, it has been seen that post-surgically they are worse than that compared to the endoscopic therapy. And number two, if we go ahead with the Whipple's, what you alluded to, chances of morbidity, post-operative surgical complications are out there. So where to stand?
Whipple's is actually, yes. The exocrine and endocrine insufficiency is more in Whipple's, less in phrase and Beggars. In fact, least in phrase actually. What we have found is, yes, there is, but it is not very statistically significant if you compare to the other modalities, because anyway, their exocrine and endocrine insufficiency becomes worse as the time goes on. Now, my advice is that if there is a definite doubt of malignancy, then you go for Whipple's. Otherwise, phrase is the procedure to do. Mortality in phrase is almost nil. And even if you do Whipple's, the mortality in case of chronic pancreatitis is very low, because these pancreas are very hard and firm, they don't leak, and the chances of leak in these patients are very low. So I think, and if you look at the literature actually has shown in number of randomized trials that the outcome and the quality of life is much better after surgery. I'm not saying that you don't do endoscopic therapy. Yes, endoscopic therapy is indicated for patients. There are specific indications where there are few stones in the head, you do not have a head mass, there is not much stricture in the body tail region. Obviously, you can go ahead with endotherapy, but it is that if it does not work more than a year, you should not attempt more than that. I have seen patients, it's my experience, I have seen patients come with 14 ERCPs and stent changes going on, and patients not being at all counseled about the possibility of surgery. I met Dr. H. Ramesh, we had a conference in Patna just 2 days back, and he said 14, I have seen 23. So I don't think that is the right procedure to keep on changing patients in which probably surgery would have a much better outcome. Yes, endotherapy is there, but there are indications for that. For patients who have a head mass, who have a huge load of stones, who have a dilated duct, multiple strictures, I think surgery, those patients should undergo surgery.
Thank you.
Thank you.
Good evening, sir.
Yeah.
Hello, yes, sir, Dr. Mayank Shekhar.
Okay. Yeah.
I've got a question for you, sir. Chronic pancreatitis with extrahepatic portal vein obstruction, with the suppose bleeding varices and all complications, GOV2 varices.
Yeah.
How to approach?
Extrahepatic portal vein obstruction is very rare in chronic pancreatitis. Most of the time, it's splenic vein thrombosis causing a left-sided portal hypertension. But yes, about 5 to 8% of those left-sided portal hypertension have an EHPVO associated. I'll talk about the EHPVO later, but if you have splenic vein thrombosis with varices, there are two ways to manage it. If these patients are surgical candidates for pancreatitis, chronic pancreatitis per se, in terms of intractable pain, these patients should undergo surgery, and if they have varices, they should undergo a splenectomy at the same time because they tend to bleed. I mean, there are studies which have shown that if you leave the spleen in place, 15 to 20% of them would bleed later. If they are not candidates for surgery, they should undergo endotherapy in terms of glue injection. If they fail with endotherapy, then you go for surgery. I think that's very clear. If there are indications for surgery from the pancreatitis point of view, you operate them and take out the spleen at the same time. If they are not candidates, you do endotherapy. Endotherapy fails, they go for surgery. And if they have a extrahepatic portal vein obstruction, these patients are good candidates for a shunt. These left-sided portal hypertension, you don't have any vein or anything to shunt, so, and splenectomy takes care of that. But if you have a EHPVO and the other veins are patent, then obviously a lyronelline shunt is the best option. But a lot of these patients might have a splenic vein thrombosis and a portal vein thrombosis, in which case you are left with probably only the mesenteric vein to do a mesocaval shunt. These patients are difficult patients. Ideally, if the pancreas is not causing too much problem, endotherapy is the treatment of choice. They fail, then we go ahead with surgery. And if these patients where you have multiple vessel thrombosis and endotherapy is not working, surgery is the option and you do a devascularization, devas surgery.
Devas surgery, yes.
Yes. Thank you. Thank you.
Do you need enzymatic replacement therapy?
Enzymatic replacement therapy only when there is exocrine dysfunction, not for pain. Exocrine, the enzyme replacement does not help in pain relief. That is very clear. You give as much as enzymes is required, pain relief will not go. Pain relief, for pain relief, you give painkillers. But yes, if there is enzyme deficiency, you give exocrine replacement therapy.
How to follow up these cases?
Follow up clinically. I think we don't have much other option. The only test available to pick up exocrine is the fecal elastase estimation test. So if you have that and the clinical features of steatorrhea, ideally then only you should give exocrine, enzyme replacement. Follow up on the basis of clinical improvement. I think that's what, on this topic at least there are people who are better knowledgeable than me to give an opinion on this, I think.
Thank you.
Thank you. Yes.
In case of EHPVO that previous person mentioned, a few of the patients are being refused surgery, needing due to chronic pancreatitis, symptomatic chronic pancreatitis, due to presence of varices.
Exactly.
In that case, obviously we have to go for shunt.
Definitely.
Is it possible to have both on the same session?
Beg your pardon, shunt.
Shunt with
if you have EHPVO, EHPVO means portal vein is obstructed and you have the splenic vein patent and the mesenteric vein patent. Yes.
But obviously varices are there.
Varices are there. Yes, you can do a shunt and you can do a surgery at the same time. A lot of people say that you do the shunt, the varices get decompressed on table. Okay, and you can do a shunt. If you do the shunt, and if you have a problem dealing with the pancreatitis at that time, you avoid the surgery for the pancreas and come back later. That is an option there.
Thank you.
Yeah. Thank you.
Thank you, sir. Moving on with our next live workshop, for which I would like to invite on stage Dr. R.K. Singh sir, Dr. Anand Singh sir, Dr. Vijay Shankar sir, and Dr. Abhay sir to kindly chair the workshop.
So we are on with the workshop, live demo. What's the plan and what's the clinical details?
Now you can see the large plot is there in the gastric fundus, which you can see here.